It's a 2 minutes we shall start discussing. There is also another reference of motor track on this side of the board. You can see it is coming from above. It's a descending track. Look at the arrow, it is a descending track. Similarly, this side it is also the descending tract. This one, this side, what is this? Lateral corticospinal tract. This side, whatever it is coming, it is anterior corticospinal tract. Along with sensory, how it goes through, it is being drawn over here. That's just for the reference. So we are taking another 2 minutes where I shall be discussing or revising whatever we have taught in the last class. Simultaneously you can finish the drawing and then we will move into it. So in the last class what we started, motor system starts from the motor cortex. Motor system is important for voluntary function, involuntary function, voluntary function and involuntary function. Motor system is connected deeply with sensory system because without sensation we can't understand how our movement is going. Motor system is deeply connected to cerebellum because that gives us proper coordination of the movement. Motor system is connected with basal ganglia because that's the basis of GPS that motor system follows, and motor system is connected or itself, it has multiple part of motor cortex like motor cortex itself or primary motor cortex, premotor cortex, supplementary motor cortex. Some part of the motor system has somatotropic organization which is known as homunculus. It is just as we see in the sensory system. What does homunculus means? It is the somatotropic orientation. So certain muscles and limbs which require very fine and complex movement, it contains or it encroaches more or major part on the cortex. It has higher representation on the cortex. Like just like you think of the map of the world. Some countries, suppose Gulf countries, they are smaller, but if we draw a financial map, their representation will be much higher. Similarly, in India also, certain states are smaller geographically, but whenever we draw a financial map, that will be higher. Certain other states, even if they are bigger, the financial representation will be low. Similarly here, motor representation is different from the actual volume of the limb. Looking at the representation, our lips, our vocal cavity, vocal cords, vocal apparatus, thumbs, hands, these are representing major area in the motor cortex because these organs can cause or they are responsible for very complex, fine and differentiated movements. That's why this is happening. Our back, definitely back muscles are important, they are postural muscle, but we can't play a guitar through our back. Remember? So that's why it doesn't require that much representational area. Similarly, the trunk is important for holding, trunk is important for posture, but with trunk we can't write. So that's why these areas have lesser representational area on the motor homunculus. Similar for the for the sensory homunculus because the fingers they contain much more number of nerve endings whereas the trunks they do not have. So that is the motor cortex. Now, always remember, whenever I am standing, continuously my standing depends on my cerebellum. Cerebellum maintains my posture, but not individually. Three different inputs are coming to cerebellum continuously. One is the proprioception input. Proprioception means joint position sense. That means I know by unconscious means that my feet are beneath and my hands are here. Even if I close my eyes, I know that. I know that I don't have to say, oh, yeah, my hands are there. No, not like that. It is unconscious. Just by unconscious. So whenever somebody asks me to handshake, unconsciously I can move it like that. This is unconscious. So it is proprioceptive input. Second input is visual input. Third input is vestibular input. So these three inputs keeps me standing, and all these inputs are going to their main relay system, that is the cerebellum. So whenever one input is taken away, visionless, so your balance will be toppled. Even in normal cases, what happens with one system or all three systems working fine, normally even with closing of our eyes, we can still stand still. Understood? So this is possible. Anyway, now coming down from the context of motor system, it is a descending system. Motor system is a descending system, and descending system means it has pyramidal tract, it has extrapyramidal tract. Pyramidal tract means the tract or the nerves which passes through the medullary pyramid. Medullary pyramid is an elevated area. It is an elevated area of the cell bodies or gray matters through which most of the motor system fibers pass through. উপর থেকে যেগুলো নিচের দিকে নামছে, those are known as corticospinal tract. Apart from this, we have corticonuclear or corticobulbar tract. These consists of pyramidal system consists of these two. What is the function of the pyramidal system? Pyramidal system function is voluntary movement. That's the important thing. Pyramidal system function is the voluntary movement. Extrapyramidal system, anything not passing through the pyramids but is a descending pathway is extrapyramidal system. Extrapyramidal system. Remember, phylogenetically, extrapyramidal system is older. ওই জন্য lower animals, they have a very good extrapyramidal system. একটা বিড়াল এখান থেকে পড়ে গেলে কিচ্ছু হবে না, আমি পড়ে গেলে ক্লাসটা বন্ধ হবে। So that's a different thing phylogenetically. But again, বিড়ালটা লেকচার দিতে পারবে না, সেটা একটা ব্যাপার। So we have encephalization. Encephalization যখন হয়েছে, যত higher animal তত encephalization বেশি হয়েছে, মানে our nervous system depend more heavily on the cortex. এটাই encephalization. যত animal higher হয়েছে তত cortical pressure, cortical dependence টা অনেক বেশি বেড়েছে। ইভেন এইখান থেকে এখানে ঝাঁপ দেবো কিনা এটা নিয়েও আমরা ক্যালকুলেশন করতে পারি, ট্রিগোনোমেট্রিও ক্যালকুলেশন করতে পারি। ইন কেস অফ আ ক্যাট আমি জানি না, বোধহয় ট্রিগোনোমেট্রি জানে না মোস্ট লাইকলি। সো ওইটা নিয়ে কোনো মানে ইস্যুই বেসিক্যালি নেই। So extrapyramidal system more or less postural control and unconscious motor control. So involuntary motor control এর সঙ্গে extrapyramidal system টা যুক্ত রয়েছে। কারা রয়েছে extrapyramidal system এর মধ্যে? আগের দিন বলেছিলাম কি vestibulospinal, rubrospinal, tectospinal, reticulospinal. এর মধ্যে reticulospinal এর নিচের উপরে ইনহিবিটরি অ্যাকশন রয়েছে, এক্সাইটেটরিও রয়েছে পন্টাইন থেকে, ইনহিবিটরি অ্যাকশনও, দুটো জিনিসই রয়েছে, যেটা জন্য ওভারঅল উপরের সিস্টেমের নিচের সিস্টেমের উপরে আপার মোটর নিউরনের লোয়ার মোটর নিউরনের উপরে ওভারঅল অ্যাকশন ইজ ইনহিবিটরি। অলওয়েজ রিমেম্বার, আপার মোটর নিউরন থেকে নিচের মোটর নিউরনের উপরে overall function is inhibitory. তাহলে extrapyramidal system, it is on that side, pyramidal system on that side. So extrapyramidal system depending, it is responsible for involuntary movements and postural adjustment, maintenance of tone and posture. এইটা হচ্ছে extrapyramidal system plus all unconscious movement. এদিকে এই যে মাথা ঘুরছে, যেদিকে সাউন্ড হচ্ছে ঘুরছে, আমি তো ভাবছি না এখানে কেউ বললো বা কিছু ভাবছি, নাথিং। Unconscious movement of head, neck, unconscious movement of hands, তুমি গাছ দিয়ে উঠছো, সামনে যেটা পাচ্ছ সেটাকে ধরছো, জলে একটা লোক ডুবে যাচ্ছে, যা পাচ্ছে সেটাকে ধরছে, সে তখন ভাবার কন্ডিশনে নেই। অল দিস আর আনকনসিয়াস মুভমেন্ট, প্রত্যেকটা এই টাইপের মুভমেন্ট হচ্ছে এক্সট্রা পিরামিডাল সিস্টেমে। লিওনেল মেসি খেলছে যখন, যে সুইং গুলো করাচ্ছে ওর এক্সট্রা পিরামিডালে ঢুকে গেছে, বিকজ অফ মেবি ল্যাকস অফ আওয়ার্স অফ প্র্যাকটিস। ওকে আর ভেবে কিছু করতে হচ্ছে না, এটা এক্সট্রা পিরামিডাল লেভেলের মধ্যে ওর ঢুকে গেছে বেসিক্যালি। যে কোনো মোমেন্টে যে গোলটা ধরো লাস্ট ওয়ার্ল্ড কাপে একটা হলো, যে পড়বার সময় ব্যাক ভলিতে যে গোলটা করছে, ওটা এক্সট্রা পিরামিডাল সিস্টেম ছাড়া হয় না। অ্যান্ড আমাদের এনসেফালাইজড হওয়ার জন্য যেটা হয়, উই নিড আওয়ার্স অ্যান্ড ডেজ অফ প্র্যাকটিস টু রিচ দ্যাট এক্সট্রা পিরামিডাল লেভেল অফ dexterity in case of movements or something like that, even in case of study, in case of medicine practice, everything ওই রিফ্লেক্স লেভেলে, আনকনসিয়াস লেভেলে চলে যাওয়াটাকে বলা হয় উইজডম। সো দ্যাট রিকোয়ার্স আ ইয়ার্স অফ প্র্যাকটিস। ক্লিয়ার এভরিবডি? এর অবধি গেল। এরপরে আমরা যেটা এসেছিলাম, যেটা আরেকটা ইম্পর্টেন্ট এখানে, হোয়াট ইজ দ্য ডিফারেন্স বিটুইন আপার মোটর নিউরন লিশন অ্যান্ড লোয়ার মোটর নিউরন লিশন। আমরা এই ছবিতে যাব, যত ক্লাস এগোতে থাকবে আমরা ছবির দিকে যাব। This was the homunculus, leave it. So anyway, upper motor neuron lesion and lower motor neuron lesion. Upper motor neuron lesion টা কোথায় হচ্ছে, upper motor neuron টা কি, lower motor neuron কি? First of all, let us have some understanding of this. Upper motor neuron means it starts from the motor cortex and it ends just before the anterior horn cell. So any descending tract all through it is the upper motor neuron. Usually both pyramidal and extrapyramidal comprises the upper motor neuron. Classically speaking, if we classically speak, upper motor neuron should only be the pyramidal tract. But in reality, upper motor neuron lesion means lesion involving pyramidal and extrapyramidal tract. Pyramidal, extrapyramidal দুটোই connected. বোঝার সুবিধার জন্য কর্টেক্স থেকে স্পাইনাল কর্ড অফ দি আপার মোটর নিউরন, অ্যান্টেরিয়র হর্ন সেল থেকে ডিস্টাল লিম্ব অফ দি লোয়ার মোটর নিউরন। সো অ্যান্টেরিয়র হর্ন থেকে ডিস্টাল লিম্বের মধ্যে কি থাকবে, এখানেই পিকচার রয়েছে, রুট গুলো থাকছে, রুট থাকছে, গ্যাংলিয়া থাকছে, স্পাইনাল নার্ভ থাকছে, মায়োনিউরাল জাংশন থাকছে, মাসল থাকছে। নিউরোমাস্কুলার জাংশন লোয়ার মোটর নিউরন, নিউরোমাস্কুলার জাংশন লোয়ার মোটর নিউরন, তোমার স্পাইনাল নার্ভ লোয়ার মোটর নিউরন, মাসল পেরিফেরি লোয়ার মোটর নিউরন, স্পাইনাল যে রুট, ডরসাল রুট গ্যাংলিয়ন, আমি আসছি এক্ষুনি, উই উইল अगेन এক্সপ্লেইন অল দিস, তো সেটাও কিন্তু লোয়ার মোটর নিউরন। সো দিস ইজ অল অ্যাবাউট দ্য সিস্টেম। এইবারে খুব ইজিলি যদি বুঝতে হয়, তাহলে রেটিকুলোস্পাইনাল ট্র্যাক্টের ওভারঅল লোয়ার ডাউন, রেটিকুলোস্পাইনাল ট্র্যাক্ট তার লোয়ার ডাউন effect is inhibitory. So যখন upper motor neuron and lower motor neuron both are working continuously, upper motor neuron is having an inhibitory effect on the lower motor neuron, more so in the stretch reflexes. Otherwise কি হতো, there will be over excitation and switching on of stretch reflex. reflex গুলো বেশি হয়ে যেত যদি upper motor neuron কাজ না করে। তাহলে যদি আমরা আবার জিনিসটাকে দেখি, upper motor neuron is from the brain, lower motor neuron is from the anterior horn cell onwards. That's the overall idea. এইবারে যদি আমাদের কিছু লিশন হয়, if there is a lesion in upper motor neuron, if there is a lesion in lower motor neuron, how to differentiate and why do we need to differentiate it? First of all, কেন আমাদেরকে differentiate করতে হবে? Anybody having any idea what is upper motor neuron lesion, lower motor neuron lesion, what's the difference? কারোর আইডিয়া আছে কিছু? কেউ দেখেছো একটাও? আমি এক্সপেক্ট করছি না দেখবে বাই দিস টাইম। ওকে, আপার মোটর নিউরন লিশন মানে লিশনটা কোথায় রয়েছে? লিশন মানে কি? What is lesion, by the way? It can be anything which is actually hindering the pathway or hindering the discharge down the line. Lesion can be anything. Lesion can be an infarction. Lesion can be an inflammatory lesion. Lesion can be a SOL, space occupying lesion. একটা টিউমার হতে পারে, একটা স্ট্রোক হতে পারে. Everything can be a lesion. Lesion can be a damage. So lesion is any kind of pathology. Any kind of pathology which is blocking the neural impulse from proximal to distal or from prior to lesion to distal to lesion. এর মাঝখানে যদি কোনো একটা lesion or pathology থাকে, তাহলে that is the lesion. Clear, everybody understood? The lesion কি টাইপের? What are the types of lesion? Just gross idea তোমাদের চাই। Stroke can be a lesion, infarction can be a lesion, inflammation can be a lesion, tumor can be a lesion. কিচ্ছু মনে রাখার দরকার নেই, জাস্ট এটা প্যাসিভ মেমোরিতে থাক, enough. So there is some kind of damage in the pathway, that is the thing. Now upper motor neuron lesion, lower motor neuron lesion. Upper motor neuron lesion means some kind of pathology in the upper pathway, either cortex 2 just before the anterior horn cell. Lower motor neuron lesion means anterior horn cell to the end. Anywhere in between, if you are having a damage, we call it lower motor neuron lesion. এগুলো পড়ার কি দরকার? এগুলো পড়ার জানার কি দরকার আছে? কোশ্চেন কামস নেক্সট, এটা তো খুব ইম্পর্টেন্ট, জানার কি দরকার আছে? লোকালাইজেশন, কোথায় হয়েছে জানতে হবে। তোমার কাছে পেশেন্ট এলো, পেশেন্টের একটা হাত একটা পা পড়ে গেছে, তুমি হাত পায়ের এমআরআই করাবে না মাথার এমআরআই করাবে, এইটাকে আন্ডারস্ট্যান্ডিং এর জন্য। তোমার কাছে পেশেন্ট এলো, দুটো পা খারাপ বাকি হাত খুব ভালো আছে, তুমি কোথাকার এমআরআইটা করাবে, স্পাইনের করাবে না মাথার করাবে না পায়ের ছবি তুলবে, এইটা বোঝার জন্য। So to differentiate between the site of the lesion, gross site of the lesion, upper motor আর lower motor কেন, mid motor নয় কেন, peripheral motor নয় কেন, কেন এখানে? কারণ দেখা গেছে upper motor shares a bundle of symptoms, lower motor shares a bundle of symptoms. So যে মোমেন্টে আমি একটা পেশেন্ট তোমার কাছে এসছে উইথ আ নিউরোলজিক্যাল ইস্যু, the moment I can divide or classify it to be either upper motor or lower motor, আমার লোকেশন ক্লিয়ার হয়ে গেল। যদি আমি বুঝি বাই সার্টেন ফিচার্স যেটা আপার মোটর টাইপ অফ লিশন, তাহলে প্রবলেম ইজ সামওয়্যার ফ্রম ব্রেন টু স্পাইনাল কর্ড, মোস্ট লাইকলি ইন দি ব্রেন। ব্রেনের মধ্যে কর্টেক্সে হতে পারে, সাবকর্টেক্সে হতে পারে, মেবি ইন দি ইন্টারনাল ক্যাপসুল, মেবি ইন দি পন্স, মেবি ইন দি মেডালা, সামওয়্যার এলস, হোয়াটএভার। তাহলে কি ব্রেনের জন্য আমি ব্রেনের ছবি করাবো? হাত আর পা গেছে, পায়ের ছবি করিয়ে কোনো লাভ নেই। আন্ডারস্টুড এভরিবডি? দিস ইজ দ্য রিজন আপার মোটরটা বোঝা দরকার। লোয়ার মোটরের ক্ষেত্রে কি হচ্ছে, লোয়ার মোটরেরও কিছু স্পেসিফিক সিম্পটম আছে যেটা দেখে আমি বুঝে যাবো জাস্ট the situation, the damage is actually lower down the track, so somewhere in the spinal cord or in the muscle or in between. তাহলে আমাকে যা টার্গেট করতে হবে, টার্গেট ফর ডায়াগনোসিস, সেটা আমার এই জোনটার মধ্যে করতে হবে। আইদার আই হ্যাভ টু গো ফর আ স্পাইনাল কর্ড ইমেজিং, অর আই উইল গো ফর আ মাসকুলার ইলেকট্রিক্যাল টেস্ট অর নিউরোমাসকুলার জাংশনের টেস্ট, এইগুলো আমরা করব। ক্লিয়ার এভরিবডি? তাহলে কেন করছি আপার মোটর নিউরন এন্ড লোয়ার মোটর নিউরনের ডিফারেন্সিয়েশন? ফার্স্ট অফ অল, ন্যাচারালি, স্ট্রেঞ্জলি এন্ড ফরচুনেটলি আপার মোটর নিউরন যত কারণেই হোক সিম্পটম গুলো এক, লোয়ার মোটর নিউরন যত কারণেই হোক সিম্পটম গুলো এক। পেশেন্ট যখন আমার কাছে আসছে, সে এসে বলছে না ডাক্তার আপার মোটর নিউরন লিশন হয়েছে, সে বলছে না, বাট আই এম সিইং সার্টেন বান্ডলস অফ সিম্পটম যেটা থেকে আই ক্যান লোকালাইজ এটা আপার মোটর নিউরন লিশন, সো আই হ্যাভ টু পুট অল দ্য ডায়াগনস্টিক রিসোর্সেস টু দ্যাট আপার সাইড। ক্লিয়ার? আবার পেশেন্ট যখন আমার কাছে আসছে পার্টিকুলার লিশন নিয়ে, এগুলো বান্ডেল অফ লোয়ার মোটর নিউরন টাইপ অফ লিশন দেখতে পাচ্ছি, তার মানে আমাকে লোয়ার জোনটাতে কনসেন্ট্রেট করতে হবে। ক্লিয়ার এভরিবডি? পেশেন্ট উইল কাম টু ইউ আইদার উইথ আই কান্ট ওয়াক, or I am having severe pain, I can't move, I am feeling weakness, এইগুলো পেশেন্ট এসে বলবে। সেখান থেকে the first question, whether this is a true neurological issue, if it is a true neurological issue, whether this is an upper motor neuron lesion or a lower motor neuron lesion, whether this is a true neurological issue, এটা এই ইয়ারের প্রযোজ্য নয়, এটা পরবর্তীকালে তোমরা শিখবে। whether it is a true neurological issue, পরীক্ষার আগে অনেকে ফেন্ট হয়ে যায় না, that is not at all a true neurological issue, that is an examination issue, কিন্তু এটা তোমরা পরবর্তীকালে বুঝতে শিখবে। রাইট নাও whatever is being presented to you is a neurological issue, that's for sure. Now you have to identify whether it's a upper motor neuron lesion or lower motor neuron lesion. Let's look at what are the features which differentiate between upper motor neuron lesion and lower motor neuron lesion. তাহলে ওভারঅল upper motor neuron lesionটা যদি আমি দেখি, upper motor neuron lesionটা কি? Medulla, corticospinal tract is, this is medulla, suppose this is medulla, this is cortex, this is midbrain, this is pons. Medullate corticospinal tract is decasseting, দু সাইডে ভাগ হয়ে যাচ্ছে, then it is coming down in the spinal cord, এবং তারপরে it is going to the lower motor neuron. Similarly the same thing over here. বোঝার সুবিধার জন্য আমি অ্যান্টেরিয়র কর্টিকোস্পাইনাল ট্র্যাক্টটাকে এই ছবিতে রাখিনি, আই হ্যাভ অনলি কেপ্ট দ্য ল্যাটারাল কর্টিকোস্পাইনাল ট্র্যাক্ট অফ আইদার সাইড, এটা জাস্ট টু মেক ইট সিম্পল। ক্লিয়ার? তাহলে আপার মোটর নিউরন লিশন মানে এনিথিং ফ্রম হিয়ার আপ টু দিস, লোয়ার মোটর নিউরন লিশন মানে এনিথিং ফ্রম হিয়ার আপ টু দিস মাসল অবধি, পুরোটা হচ্ছে লোয়ার মোটর নিউরন লিশন। ক্লিয়ার? আপার মোটর নিউরনের লোয়ার মোটরের উপরে নেগেটিভ ইনফ্লুয়েন্স রয়েছে, আপার মোটর নিউরনের লোয়ার মোটর নিউরনের উপরে ইনহিবিটরি রেসপন্স রয়েছে। এইবার চলে আসছি কি হবে আপার মোটর নিউরন লিশন হলে। ফার্স্ট অফ অল, দিস ইনহিবিটরি রেসপন্স অর ইনহিবিটরি ইনফ্লুয়েন্স উইল বি লস্ট। So lower motor neuroner upore upper motor neuroner je inhibitory response which is coming from the reticulospinal tract, that will be lost. Jei momente this is lost, what will happen? The stretch reflexes in the lower motor neuron will be high or low? High. Gamma motor neuron discharge in the lower motor neuron will be high or low? High. কারণ কি আপার মোটরটা তো এটার উপরে আলফা এন্ড গামাকে ডাউন করে রাখছে। গামাটা কি করছে? গামা ইজ দ্য রিফ্লেক্স অ্যাক্টিভিটি ইন দি লেভেল, আলফা কি অ্যাকচুয়ালি মুভমেন্ট অ্যাক্টিভিটি ইন দি লেভেল। ক্লিয়ার এভরিবডি? আলফা হচ্ছে মাসেলের মেন ফাইবার গুলো, গামা হচ্ছে কি ভিতরে যে অর্গান গুলো রয়েছে, স্ট্রেচ রিফ্লেক্সের অর্গান, গলজি টেন্ডন অর্গান, সেই জায়গাগুলোতে এটা কাজ করছে। তাহলে দ্য মোমেন্ট আপার মোটর নিউরন লিশন ইজ হ্যাপেনিং, which can happen in the cortex, which can happen in the midbrain, which can happen in the pons, which can happen in the medulla, which can happen anywhere down the line up to this. If that happens, inhibitory response on lower motor neuron will be lost. The moment this happens, so what will happen? Tone of the muscles, what will happen? Will it be high or low? In upper motor neuron lesion, it will be high. কি করে বুঝবো? একটা পেশেন্টকে ডেকে এনে হাতটাকে এভাবে মুভ করাবে, হাতটাকে এভাবে মুভ করাবে, যে সাইডে আপার মোটর নিউরন লিশন, ইউ উইল ফিল দ্যাট সাইড ইজ টাইটার, টাইট, মুভ করাতে একটু অসুবিধা হচ্ছে। অন্য সাইডটা ইজি, অন্য সাইডটা ইজি, এই সাইডটা টাইটার, এই সাইডটা টাইট। তুমি প্যাসিভ মুভ করাবে, কিভাবে প্যাসিভ মুভ করাবে? হাতটা ধরে এই, ক্লিয়ার? সিমিলার। তাহলে এই দিকটায় দেখা যাচ্ছে দিস ইজ ইজি, এই দিকটায় দেখা যাচ্ছে দিস ইজ টাইট। দিস ইজ প্যাসিভ মুভমেন্ট। প্যাসিভ মুভমেন্ট কেন? কারণ পেশেন্ট নিজে করছে না, ইউ আর মেকিং দি মুভমেন্ট। So that's why a passive movement. So what I am doing? Passive flexion and extension, passive flexion and extension. আরেকজন করে দিচ্ছে আমার হাতে। That means এই সাইডটা টোনটা বেশি। Clear everybody? তাহলে যদি রাইট সাইডে টোন বেশি হয়, তাহলে রাইট সাইডে I am getting a right sided upper motor neuron lesion like feature. Cause depends, cause এ পরে আসবো। তাহলে রাইট সাইডে I am getting right sided upper motor neuronal lesion feature. That is one. Tone will be high. What will happen to the reflex? কি কি রিফ্লেক্স আছে হাতে বা পায়ে? হাতেই যখন বলছি, হাতে বাইসেপস জার্ক, ট্রাইসেপস জার্ক, সুপাইনেটার জার্ক করা হয়েছে, আরো অনেকগুলো রিফ্লেক্স আছে, সেগুলো তোমাদের আমরা এখনো করাইনি, পরে শিখবে। তো অ্যাট লিস্ট দিস বিগার জার্কস, যেগুলো C5, C6, C8, T1, এই যে রিফ্লেক্স গুলো রয়েছে। সো what will happen to these reflexes? Reflexes will be exaggerated. এক্সাজারেটেড রিফ্লেক্স বেড়ে যাবে। তাহলে এখন আমরা স্টার্ট করেছি রাইট সাইডেড আপার মোটর নিউরন লিশন। ফার্স্ট পয়েন্ট পেয়েছি রাইট সাইডেড টোন ইজ ইনক্রিজড। সেকেন্ড, লেফট সাইডে রিফ্লেক্স, বাইসেপস জার্ক করলাম, দিস লেফট সাইডে দিস রিফ্লেক্স ইজ হ্যাপেনিং। লেফট সাইড ইজ নরমাল, নরমাল, নরমাল ইজ দিস। রাইট সাইড অ্যাবনরমাল, 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 এক্সাজারেটেড রিফ্লেক্স, রিফ্লেক্সটা বেড়ে যাচ্ছে। আপার মোটর নিউরন লিশন, ফার্স্ট হচ্ছে টোন বাড়ছে, দুই হচ্ছে রিফ্লেক্স বাড়ছে। ফার্স্ট হচ্ছে টোন বাড়ছে, দুই হচ্ছে রিফ্লেক্স বাড়ছে। থার্ড, there is a possibility of presence of clonus. কি? ফার্স্ট রিদমিক অ্যাগনিস্ট অ্যান্টাগনিস্টিক মাসল মুভমেন্ট। যদি এখানে তো আমি এই ক্লাসে দেখানো ইম্পসিবল, বাট আই এম স্টিল ট্রাইং টু ডু। সাপোজ এটা পা, এইটা পায়ের পাতা, ফিট, মাই হ্যান্ড, মাই পাম ইজ ফিট and this is the leg. এই কন্ডিশনে ankle কে if you passively stretch like that, all of a sudden this will move like this. This is clonus. So rhythmic, agonistic, antagonistic, rhythmic dorsiflexion and plantar flexion is happening. কেন হচ্ছে? কারণ stretch reflex and inverse stretch reflex simultaneously they are on, এবং upper motor থেকে inhibitory response না থাকায় there is nobody to check this. So persistently whenever you are stretching, inverse stretch reflex is normally, নরমালটা কি? যখন আমি স্ট্রেচ করি অপোজিট অ্যান্টাগনিস্টিক মাসলকে নেগেটিভলি ইনহিবিট করে দেওয়া হয়, ইনহিবিট করে দেওয়া হয় যে কোনো, সেই জন্যই আই ক্যান ডু সামথিং। সাপোজ ইন নর্মাল সিচুয়েশন ইফ আই ফ্লেক্স মাই আর্ম, biceps is flexing but triceps must be relaxed. If biceps is flexing and triceps is also flexing, what will happen? It will be this movement, pendular movement, continuously this is happening. This usually is checked by a proper inverse stretch reflex. Normally stretch reflex and inverse stretch reflex, Golgi tendon organ, আলাদা ক্লাস হয়েছে, we will এখানে আর ওটার মধ্যে ঢুকতে পারবো না, অত টাইমও এটা পাচ্ছি না, but anything is, important thing is upper agonist and antagonist, they are always in an unison, on in harmony. So যখন আমি অ্যাগনিস্টিক মাসল করছি, অ্যান্টাগনিস্টিক মাসল should be relaxed. কিন্তু এক্ষেত্রে যেটা হচ্ছে, since upper motor neuron থেকে inhibitory response on the inverse stretch reflex আসছে না, that is also on. So this stretch is also on, this stretch is also on. So there will be rhythmic beating movement, continuous dorsiflexion, plantar flexion. পাঁচটার বেশি হলে we call the clonus significant. অনেক সময় পেশেন্টের পায়ে ব্যথা লাগে, পা সরিয়ে নিতে চায়, those are insignificant. পাঁচটার বেশি ঠিক এই মুভমেন্ট আসবে, পায়ের ক্ষেত্রে এই মুভমেন্ট আসবে, একদম absolutely this movement will come in case of the legs. তোমাকে পাটাকে ধরে জাস্ট এই করে দিতে হয়. So that can be demonstrated in the word on actual patient. Right now it is beyond my scope to demonstrate actually, but this clonus is an upper motor neuronal lesion, the feature. Okay, now coming to what will happen to the muscle, whether the muscle will be atrophied, muscle ki khoye jabe, decay hoye jabe, naki muscle will be hypertrophied, or it will remain something as it is. Why? Upper motor neuron lesion, what will happen to the muscle? There will be some degree of atrophy, but not much. That's the term. Why there will be some degree of atrophy? Definitely একটা পেশেন্ট যদি এই সাইডটা উইকনেস থাকে, আপার মোটর নিউরন লিশন হয়ে থাকে, he can't walk or he is not using that too much. So there is some degree of disuse atrophy, but simultaneously you need to remember that limb, affected limb, is persistently under high tone. So affected limb is 24/7 is doing some kind of isometric exercise. So even in the face of disuse, the limb will not be that much atrophied. Some degree of atrophy, that is also variable on time. Karo jodi 6 মাস ধরে হয়ে থাকে, that's a different thing. Their feature will be slightly different. Karo 2 দিন হলে their feature will be slightly different. Karo 10 দিন হলে their feature will be something different. And after years it will be difficult to actually differentiate. কিছু হয়েছিল বলেই after years হয়তো বুঝতে পারা যাবে না. So that is the idea. So 4 points is a must for the upper motor neuron lesion. One is tone will be high, reflex will be high on that side, then there might be clonus, not in all cases clonus positive, সব জায়গাতে হবে না, clonus নেই বলে আপার মোটর বলছি না এরকম নয়, কিন্তু clonus আছে, that is making you more sanguine that this is upper motor neuron, but not in every stroke patient with upper motor neuron lesion they do present with clonus, সব জায়গায় থাকে না, but tone will be high, definitely reflexes will be exaggerated. Plantar reflex, যেটা Babinski sign, that will be positive. Plantar যদি তোমাদের মনে থাকে আমরা এই ক্লাসে করিয়েছিলাম. So plantar reflex এ কি হবে? There will be exaggeration. The great toe will be extensive. I mean great toe একটা extension হবে, and that will be exaggerated extension. Great toe টা upgoing great toe হবে. Normally কি plantar, normally এটা যদি toe হয়, toe should go down. This is the normal plantar, or nothing is happening. That is also normal plantar, absent. But in case of upper motor neuron lesion, toe will go back, extension. I can't do it over here, just with this analogy I am trying to make you understand. This is upper motor neuron lesion. Coming to the lower motor neuron lesion, what will happen? Lower motor neuron lesion means upper motor neuron is intact. Neuron lesion means upper motor neuron is intact. So the inhibitory response that is coming from above is intact. Inhibitory response that is coming from above is intact. So whatever is happening, where it is happening? It is happening either here or here or here. So এখানে কোন কোন জায়গায় হতে পারে? এটা এই এরকম জায়গাতে আসতে পারে, এইখানে হতে পারে, the ventral root or the motor root এখানে হতে পারে, এই নার্ভে হতে পারে, or we can also have it over here. নার্ভের ক্ষেত্রে হতে পারে, গ্যাংলিয়নের ক্ষেত্রে হতে পারে, it can go মাসলে হতে পারে, মাসলের যে জায়গাতে নার্ভটা ঢুকছে, মায়োনিউরাল জাংশন, গুলেনবারি সিনড্রোম, মাইসথেনিয়া গ্রেভিসের সময় যেটা পড়েছিলে, সো মাসেলের যেই জায়গাতে ঢুকছে এনএমজে নিউরোমাসকুলার জাংশন, সেখানেও ইস্যু হলে লোয়ার মোটর লাইক ফিচার্স আসবে। লোয়ার মোটর নিউরন লাইক ফিচার্স, হোয়াট আর দোজ ফিচার্স? ফার্স্ট অফ অল ট্রাই টু আন্ডারস্ট্যান্ড inhibitory response from above is intact, so at least there will be no extra response because inhibition is coming. বাবা মা অলরেডি বলছে এই দৌড়াবি না বেশি, তারপরে আবার ছেলের পায়ে ব্যথা, তাহলে যা হবে সেইটা হবে লোয়ার মোটর নিউরন লিশন। Clear everybody? So everything will be down. Lower motor neuron lesion, anything in the lower motor zone means there will be very reduced action potential reaching the peripheral organ. আমরা তো as physician we get intact patient, পেশেন্টের হাত পা কাটা অবস্থায় তো আমরা আসছে না, it is the complete patient is coming as a human being and he is mentioning or she is mentioning I can't do this. From there retrospectively we are reaching over here. এইটাই তোমাদের শেখানো হচ্ছে এই মোমেন্টে। তাহলে লোয়ার মোটর নিউরন লিশনে কি হচ্ছে? muscle peripheral organ is getting very reduced strain of action potential, or ভীষণ low stimuli is reaching or no stimuli is reaching the peripheral organ. What will happen? Tone will be low or very low, tone একদম ডাউন। আলফা মোটর নিউরন একদমই কিছু পাচ্ছে না, গামা মোটর নিউরনের উপরে আপার মোটর নিউরনের ইনহিবিটরিটা রয়ে গেছে, tone will be very reduced. So reduced tone, what will happen to the reflex? Again reduced reflex, because reflex এর জন্য what I need some sensory pathway from the periphery, it goes to the central processor, from there efferent comes, motor comes back to the muscle, তারপরেই আমার কিন্তু রিফ্লেক্স গুলো হয়। এই যে মোটর কামস ব্যাক টু দ্য মাসল, দিস ইজ দি লোয়ার মোটর নিউরন। তো লিশন তো এইখানেই, সো নাথিং, নো ইফেক্টর or no motor response is coming to the muscle, reflexes are lost. So lower motor neuron lesion, deep and superficial, both reflexes are lost. Tone is reduced, there will be hypotonia, reflexes are lost. What will happen to muscle? Will there be atrophy, hypertrophy? What? There will be severe atrophy. Severe atrophy. কারণ কি মাসলটা ডিসইউজ হচ্ছে, muscle is also not getting neural stimuli, and that is right from the day one of the lesion. So there will be severe atrophy. And there are few terms যেটা পরবর্তীকালে তোমরা পড়বে, fibrillation. It's a little difficult. And second is fasciculation. These are particularly muscle related involuntary movement. Kind of this, একটু tremor টাইপের, but this can be differentiated. একটু tremor টাইপের আসতে পারে, fibrillation or fasciculation. অনেক সময় দেখেছো হয়তো চুপচাপ বসে আছো, all of a sudden চোখের পাতাটা একটু কেঁপে উঠছে, that is natural, but অথবা হাতের কোনো একটা জায়গা বা পায়ের কোনো একটা জায়গায় muscle is moving, that is natural. Fibrillation and fasciculation is very close to that kind of a thing, which is pathological and seen in lower motor neuron lesion. For today, since patients are not in front of you, what should be the take home message? Clonus found in upper motor neuron lesion, fasciculation found in lower motor neuron lesion. What else? So we are making a division between upper motor neuron lesion and lower motor neuron lesion. There is 50% chance. So if any question is asked from the neuro, definitely upper motor neuron lesion and lower motor neuron lesion differentiation should come. Vision important for the examination. So upper motor neuron lesion এ টোন বাড়ছে, রিফ্লেক্স এক্সাজারেট হচ্ছে, মাসল অ্যাট্রফি খুব বেশি হচ্ছে না, রিডিউসড অ্যাট্রফি নট মাচ, অ্যান্ড দেয়ার মাইট বি ক্লোনাস। লোয়ার মোটর নিউরন লিশনে টোন কমছে, রিফ্লেক্স কমছে, ফিব্রিলেশন, ফ্যাসিকুলেশন মে বি প্রেজেন্ট, অ্যান্ড আর atrophy, severe atrophy is found in case of lower motor neuron lesion. Clear everybody? So far, okay. Let's talk a little bit about the spinal cord and the section that we have drawn, and we will complete this now. So try to understand. This is the front part, this is the back part. So front part is anterior. In most of the textbook it is written as ventral. Back part is posterior. In most of the textbook it is written as dorsal. Ventral is the motor part. Dorsal is the sensory part. তাহলে বোঝার চেষ্টা করো, যা কিছু এর উপরে হচ্ছে, anything above this, is dealing with the sensory system. Anything below this is dealing with the motor system. Now in spinal cord, বাইরে white matter না বাইরে gray matter? বাইরে white matter, ভিতরে gray matter. তাহলে where is the gray matter? এইটা হচ্ছে gray matter. আর এই যে বাইরের এই পার্টগুলো, এই যে বাইরের এই পার্টগুলো, these are the white matters. Clear everybody? Clear? White matter কি, gray matter কি? White matter হচ্ছে অ্যাকশন, gray matter কি, ganglion or cell body. White matter action, gray matter ganglion, cell body or synapse. Try to understand. Synapse. এই যে ছবিগুলো আঁকি, এই যে এখানে যেমন একটা এসে সেখান থেকে পরেরটা যাচ্ছে, what is this? This is a synapse না? This is a sign of synapse. তো এটা কোথায় রয়েছে? এটা gray matter এর মধ্যে রয়েছে। ক্লিয়ার? এইবারে এইটা কি, এইটা কি? রুট, রুট। তাহলে এটা কি রুট? মোটর রুট অর ভেন্ট্রাল রুট? উপরেরটা কি রুট? ডরসাল রুট অর সেন্সরি রুট? সেন্সরি বা মোটরটা আমি বলছি মনে রাখার জন্য, বইতে অ্যাকচুয়ালি ভেন্ট্রাল অ্যান্ড ডরসাল করেই সব জায়গাতে রয়েছে, জাস্ট টু হ্যামার দ্য কনসেপ্ট। সেই জন্য কামিং ব্যাক, there is a bulb like structure both side. This is dorsal root ganglion. Ganglion means ki, what is ganglion? So ganglion is, it is the cell body or synapse anywhere outside the CNS, that is known as ganglion. So CNS ki, spinal cord and brain. So these are just outside the spinal cord na. So this is a ganglion, karon ekhane ekta synapse hocche othoba cell body royeche, that is the reason this is a ganglion. So this is dorsal root ganglion. Clear everybody? এইখানে তিনটে পার্ট আছে of the gray matter. There are three part, তিনটে তিন কোনা জায়গা রয়েছে, triangular shape. So this is horn, this is horn, this is horn. শিঙের মতো দেখতে, horn, cow horn. Similarly this is horn. হর্ন গুলোর নামও দেওয়া হচ্ছে ডিপেন্ডিং অন দ্য পজিশন। সো দিস ইজ ভেন্ট্রাল অ্যান্টেরিয়র হর্ন, দিস ইজ ল্যাটারাল হর্ন, দিস ইজ ডরসাল হর্ন। ক্লিয়ার এভরিবডি? অ্যান্টেরিয়র হর্ন, ডরসাল হর্ন, ভেন্ট্রাল হর্ন। প্রত্যেকের ফাংশন ইজ অলসো ডিফারেন্ট। কিরকম ফাংশন? দিস পার্ট ইজ কানেক্টেড উইথ সেন্সরি, দিস ইজ অলসো কানেক্টেড উইথ সেন্সরি, দিস ইজ অলসো কানেক্টেড উইথ সেন্সরি, আপার পার্টটা। And lower part, a horn, this is connected with motor. Clear everybody? So jodi, if you get any lesion here, what will happen? The patient will be having motor complaint, movement korte parbe na, but whether the patient will have any sensory complaint? No. So motor horn issue hoyeche, kichu howar kotha noy. Clear everybody? So isolated motor horn issue, tale motor complaint, patient can move, reflexes will be down, kind of that. Anterior horn cell royeche, there is anterior horn cell. Anterior horn cell means what? The horn cell that is present in the anterior horn, that means the motor horn. Anterior horn cell is the motor nucleus, lower motor neuron er first step, anterior horn cell. Clear everybody? Just from the nomenclature you can reach kothay. Tale anterior horn cell disease mane ki, only motor related things will happen, only motor related things will happen anterior horn cell jodi disease affected hoy. Clear everybody? Acha, এইবারে আরেকটু if we just combine the sensory and the motor. So if we look at the dorsal part, this is the part through which usually cutaneous sensation goes. This is the part, the next part through which cutaneous and muscle sensation goes, and this is the part through which cutaneous, muscle and visual sensation goes. Ganglia, it is coming from here and then it is going above, it is going above. Sensory মানে কি? Sensory মানে তো এরকমই, বাইরে থেকে আসছে and it is going above. Clear? এই জায়গাতে I have drawn two more structure and I have divided those structures a little bit more. So এগুলো কি? Fasciculus. What are those fasciculus? Fasciculus cuneatus, fasciculus gracilis. Fasciculus cuneatus, fasciculus gracilis. Gracilis for the lower, cuneatus for the upper. How you can remember? Gratitude, low down. Fasciculus gracilis, lower part. Fasciculus cuneatus, upper part is remaining. So that is the upper part. Clear everybody? So this part, এই যে জায়গাটা, this is outside This is outside the gray matter. What is this? White matter. White matter মানে কি? Action will pass through. So action কোন দিকে যাচ্ছে? This is the action of the sensory tract. কোনখানে এই অ্যাকশন যাচ্ছে? এটা উপরের দিকে চলে যাচ্ছে। কোথায় যাচ্ছে? ফার্স্ট ইট ইজ গোয়িং টু দি মেডালা, তারপরে এটা কোথায় যাচ্ছে? ক্রসিং, তারপরে কোথায় যাচ্ছে? থ্যালামাস, তারপরে কোথায় যাচ্ছে? সোমাটোসেন্সরি কর্টেক্স। ক্লিয়ার? তাহলে দিস ইজ কামিং ফ্রম দি ল্যাটারাল সাইড, দিস ইজ পাসিং থ্রু দি posterior column, this is crossing over medulla, going to the thalamus, going to the opposite side of সোমাটোসেন্সরি কর্টেক্স। তাহলে এইখানে আমার এই হাত থেকে যে posterior column sensation যাচ্ছে, that is going to the opposite side of somatosensory cortex. Everybody understood? Clear everybody? Now coming to the point, what are the sensations that passes through dorsal column? Fine touch, proprioception, vibration, stereognosis, 2-point discrimination. Clear? তাহলে খুব সিম্পল বললে, কেউ হাত বুলাচ্ছে, this is reaching to my mind through dorsal column. Clear everybody? হয়ে গেল? তাহলে ফাইন টাচ, ভাইব্রেশন, reaching to my mind through dorsal column. 2-point discrimination, whether this is 2 points or 1 point, this is reaching to my mind through dorsal column. Crossover at medulla, going to thalamus. Why to thalamus? Because thalamus is the sensory relay system. Thalamus is the sensory relay system. যা কিছু পাস করবে thalamus দিয়ে পাস করতে হবে, and it will go to the somatosensory cortex. Where is the somatosensory cortex? Area 1, 2, 3 or 3, 1, 2. 2, 1, 3, same thing. Area 2, area 312 নয় কিন্তু, area 3, area 2, area 1. ফলে কেউ যদি এরিয়া 1, এরিয়া 2, এরিয়া 3 বলে, তাকে ফাঁসি দেওয়া যাবে না। গট মাই পয়েন্ট? কাছাকাছি গেলেই ইটস ওকে। কোথায় থাকছে? ইজ ইট ইন ফ্রন্ট অফ দ্য সার্কাস অর ব্যাক ওয়ার্ডস দ্য সার্কাস? ব্যাক সাইড অফ দ্য ব্রেন, ব্যাক, posterior সার্কাস, সেন্ট্রাল সার্কাসের পিছনে থাকছে। ক্লিয়ার এভরিবডি? এই অবধি। নাও কামিং টু দ্য নেক্সট পার্ট। যখন আমরা এবারে উপর থেকে যখন আমরা আসছি, কামিং টু দিস, সাপোজ, আচ্ছা, this was এই যে ডরসাল কলাম, আজকে যতটা হবে রাখবো, পরের দিন এখান থেকেই আমরা we will start. Clear? So there will be another class on the same motor system and integrated with the sensory system. ডরসাল কলাম দিয়ে যেটা যাচ্ছে, this is conscious proprioception. মানে আমি বুঝতে পারছি, this is conscious proprioception, যেটা ডরসাল কলাম দিয়ে যাচ্ছে। There is unconscious proprioception too. Unconscious proprioception কোথায় ইউজ হচ্ছে? তুমি মাঠে ক্রিকেট খেলতে গেছো, অল অফ আ সাডেন তুমি পয়েন্টে ফিল্ডিং করছো, a ball is coming to the left side of yours, তুমি জাম্প করলে, then whatever happens, that is unconscious proprioception. In the air, whatever is happening, unconscious proprioception. পড়বার সময় whatever is happening, unconscious proprioception. ওখানে আমি ভাবতে পারবো, আমি এখন নিচে পড়ছি, নিউটন বলেছিলেন কিন্তু পাই থিটা মাথায় লেগে যাবে। It is not possible. So whatever is happening, unconscious proprioception কোথা দিয়ে যাচ্ছে? Unconscious proprioception passes through this, and this is spinocerebellar pathway. দেখো, the নামটাই এমন সাজেস্ট করছে, the name suggests there is no cortex in it, so it is bypassing the cortex. খুব কুইক কাজের জন্য কর্টেক্সের উপর নেচার ভরসা করেনি, স্পাইন থেকে ডাইরেক্ট সেরিবেলামে তুলে দিয়েছে। So these are, গড ফরবিড, অ্যাক্সিডেন্ট হচ্ছে, গাড়ি ধাক্কা মারবে, অ্যাট দ্যাট পয়েন্ট স্পাইনোসেরিবেলার পাথওয়ে, তখন যখন আর ভাবার টাইম থাকে না, তুমি ব্রেকটা মেরেছো কিন্তু ইনার্শিয়া রান করছে, and another half a second you will hit somewhere. এই টাইমটা স্পাইনোসেরিবেলার পাথওয়ে, যা কিছু করবে, ব্রেস পজিশন আর হোয়াট এভার, স্পাইনোসেরি, তুমি আর ভেবে কিছু করবে না। তোমাদের অনেকে পরীক্ষাতে স্পাইনোসেরিবেলার পাথওয়ে দিয়েই লিখছে আজকাল, আমাদের এটা একটু চেঞ্জ করাতে হবে, একটু কর্টেক্স ঢোকাতে হবে, সেই জন্য খুব অসুবিধা হচ্ছে। বেসিক্যালি আমাদের ভিশনে হেমিয়ানোপিয়া হয়ে যাচ্ছে, এক চোখ বন্ধ করে দেখতে হয় খাতা। ইট ইজ such a difficult scenario for us. Anyway, so this is the spinocerebellar pathway. এখানে আরেকটা জিনিস আঁকা আছে, what is that? This is the pathway of the column. This is the column. Column মানে কি অ্যাকশন যেটা হোয়াইট ম্যাটারের থ্রু দিয়ে যাচ্ছে, that is the column. This is the column for lateral spinothalamic tract. This is the column for the lateral spinothalamic tract. So lateral spinothalamic tract কি হচ্ছে, এখান দিয়ে যা ঢুকছে বা এই দিক থেকে যা ঢুকছে, সেন্সারি যা ঢুকছে, সেন্সারি এই থ্রু দিয়ে উপরে উঠে যাচ্ছে। সেন্সারিটা at that level is crossing lateral spinothalamic tract and it deals with pain and temperature. It deals with pain and temperature. So হাতের থেকে যা কিছু পেইনফুল স্টিমুলি অর টেম্পারেচার স্টিমুলি সেটা ল্যাটারাল কর্টিকোস্পাইনাল ট্র্যাক্ট দিয়ে উপরের দিকে উঠছে। কিভাবে আসছে? ডরসাল রুট দিয়ে ঢুকবে, ঢুকে it will cross in the same level, it will pass through the lateral corticospinal tract, it will go up, go straight to the thalamus of the contralateral side because it is already contralateral here, and from thalamus it will go into the somatosensory cortex. Again area 3, 1, 2, 1, 2, 3, whatever. Clear? Lateral corticospinal tract. Clear? Now coming to this. This is for the descending pathway. This is for the descending pathway. And this is also for the descending pathway. This is also for the descending pathway. What is the difference? Straight arrow, curved arrow. Straight arrow, curved arrow. Medial, lateral. Chatte to position. Everybody understood? Straight arrow, curved arrow. One more minute and I will stop this. Then from here we will move on to the next day. Straight arrow, curved arrow. কি হচ্ছে? This is straight arrow is for the voluntary tract. Pyramidal. Straight arrow, pyramidal tract. এইটা যেটা দেওয়া আছে, this is for the lateral corticospinal tract, যেটা distally আছে, sorry, যেটা laterally আছে. This is lateral tract, and pyramidal tract is for the voluntary control, and voluntary control is for the distal muscle, and distal muscle, by that we mean distal limbs. Distal muscle কি? Body থেকে distally কি আছে? Limbs. Clear? So pyramidal tract, straight arrow, conscious motor. This is conscious motor, and যেহেতু এটা lateral corticospinal tract এ আছে, this is causing voluntary motor activity of the limbs. Similarly, straight arrow here, anterior corticospinal tract, straight arrow, anterior corticospinal tract. This is also conscious motor of proximal muscle and trunk muscle. So this is conscious voluntary control of trunk. Conscious voluntary control of trunk. What else this? Curved arrow, and curved arrow, this is extrapyramidal. This is extrapyramidal. Extrapyramidal means involuntary. So all the tracts, involuntary আছে সেটার কার্ভড অ্যারো মানে দিস ইজ ফর দ্য লিম্বস, আর যেটা মিডিয়ালি আছে সেটার কার্ভড অ্যারো মানে দিস ইজ ফর দ্য ট্রাঙ্ক। সো অল দিস ফিচার্স, extrapyramidal, reticulospinal, rubrospinal, tectospinal, vestibulospinal, ওই কার্ভড অ্যারো থ্রু দিয়ে যাচ্ছে। তার ওরিয়েন্টেশন ইনসাইড দি স্পাইনাল কর্ডটা ওই রকম, যেটা ল্যাটারালি আছে সেটা ডিস্টাল, যেটা মিডিয়ালি আছে সেটা ট্রাঙ্ক। ইনভলান্টারি। ক্লিয়ার এভরিবডি? ক্লিয়ার পুরো জিনিসটা? গো থ্রু ইট মাল্টিপল টাইমস ওয়ান্স ইউ গো ব্যাক হোম। আমরা জাস্ট এই পার্টটা শেষ করলাম। পরের দিন আই উইল স্টার্ট ফ্রম হিয়ার। ফ্রম দেয়ার আই উইল গো ইনটু ভেরিয়াস স্পাইনাল কর্ড লিশন, যেটুকু তোমাদের লাগবে, যার মধ্যে একটা ভীষণ ইম্পর্টেন্ট হচ্ছে স্পাইনাল শক অ্যান্ড স্টেজেস, ব্রাউন সেকার্ট সিন্ড্রোম, টেবিস ডরসালিস, মোটো নিউরন ডিজিজ, আর যেগুলো সময় পাবো বলে দেবো নেক্সট ডে, রম্বাক সাইন, অল দিস থিংস। ক্লিয়ার এভরিবডি? There will be another class on the same topic as an extension.
Which is a long question and a short question. So involving the ear, we have a clinical questions or clinical problem that we see often in our clinical life. As well, the anatomy of this ear involving this different sector of the ear. We see that this coming as a long exam question, and as well we see the ear is fragmented, and tested in examination in form short notes. So explain why and the long questions and as well as the short notes is important for us for preparing for the exams, and as well as we see number of cases in our clinical life involving this ear and the different segments of the ear. Now, the topic which we are going to discuss about is we are going to talk about the ear in terms of very precise and very accessible point of the ear, which is relevant for your exams. So the point of today's lecture will be focusing on the part of the ear we call them as external ear, and that external ear have got clinical importance to it. We'll be talking about it. And next on we'll be moving to this particular ear we call them as middle ear. The middle ear we have to prepare a little detail about it because we see the clinical problems based on this particular middle ear, and as well as this particular middle ear morphology or architecture itself draws several questions in exam. So these are the 2 points on the ear we'll be focusing on. The inner ear, which is involving with this auditory mechanism and as well as equilibrium, we are not going to discuss about it. So in a 1 hour lecture, we are going to cover these particular aspects of the ear, and that also involves the clinical problems too. So this is what we begin with, is the ear. So for the descriptive part, it is easy to describe this ear in a 3 forms or 3 segments. We call them as the external ear, which is visible part, partly it's going on a tunnel or loop structure. Then it leads to the deeper structure ear, we call them as inner ear, which is basically holding this particular ear mechanism of audition. So that involves with complex clinical and as well as chemical mechanisms or output generations, which actually draws into some potentials, which is reflected as a chemical energy to electrical energy to convert it into the impulse and carried through the nerves, which is known as vestibulocochlear nerve, and goes to the higher centers of the brain. And this particular ear, which is involving this particular region, which is the inner ear, holds the equilibrium. That means it holds the balance. If you are standing in a still position, if you are sitting straight or sitting in a desired position, that is because of the balance which you are maintaining. That equilibrium also is contributed by the posterior part of the ear, which is known as inner ear. So for the discussion I have mentioned, we'll be talking about this particular ear, which is external ear, and this middle ear, which is our point of concern, and later on we'll be just like breezing through this external ear, just the parts of it will be describing on. So to start with this particular ear, which is external ear. So external ear have got parts. As you can see, this particular part is visible for us. Which is the visible part, we call them the spina or auricle, which is the external side we have. And that particular auricle is continued in a tunnel form. We call them as external auditory meatus, which is going through this particular tunnel or external auditory tube or external auditory canal. And that leads to a hexagonal shaped structure, which you in a deep blue structure which you are seeing here, which is known as the middle ear, and which is again communicated on the back side, which is the orange structure in the back, which is inner structures. So these are the kind of like parts of the ear which is we are seeing in short. Now talking about the functions of the ear, we see that this particular ear, the functions is primarily hearing. So whatever the things that we are hearing, these are the things which is only helping us to do these things. So we do not have any accessory or any other organs to help these things out. So this is the only organ which is dealing with the hearing, and as well as I am saying the balance or equilibrium. If you are standing and walking peacefully in a straight manner or in a desired manner, it is one of the things which is contributing towards the equilibrium or balance of the body. Now, looking in the broader picture of this particular ear which you are seeing here, this is a cross section picture, and we can easily identify different segments of the ear. This ear segment which you are seeing here is the external ear, which we are going to start to talking about. This area which is known as the spina, also known as auricle, it has several segments which is we are going to talk this briefly. Then it leads to this particular tunnel, which is external auditory canal, so which ends into this particular or limits into this particular region. We call them tympanic membrane, which is limiting this particular extent of external ear. So this particular limiting membrane, which is known as tympanic membrane, which is limiting here this external ear, and the doorway ends over there. Beyond this, we call them as middle ear. So this particular chamber which you seeing here, hexagonal, which is lying over here in the petrous part of the temporal bone, we call them as middle ear, which is again communicated with the deeper ear, which is known as this spiral or snail shaped organ of Corti, which is communicated through this particular nerves, which is going to take this impulse which is generated out here. So this is a rough architecture of the ear. So we take this external ear first, then we talk about the middle ear, then we will be breezing through this particular inner ear. So parts of components of this external ear is that we have this auricle, which is having the morphology of different shape. So functions of the auricle is to attract or catch these sound waves. Whatever the directions we have the sound waves coming, it has different complex geometrical analysis which is holding this particular sound waves from different directions and diverts towards or channels towards this external acoustic meatus or external auditory meatus, which is taking this particular sound wave to be just like reflected on this particular tympanic membrane, which actually vibrates, and this vibration carried through and generate this particular pace subsequently. So this particular thing we have to know about the parts of this particular pinas. So they have some kind of like a morphological or kind of structural thing related to this pinna. We have this particular curvature here, we call them as helix. Opposite to the curvature, we have this particular deep line, we call them as anti-helix. This particular pinna is entirely cartilaginous. We have seen that different forms of cartilage is there. We have fibrocartilage, hyaline cartilage, elastic cartilage. This particular pinna is a collapsible structure, is made of the cartilage which is known as the elastic cartilage. That means it is kind of collapsible, and again it can get the shape back if it is collapsed. So this particular helix and anti-helix and then leads to this particular central depression which is lying over there, we call them as concha. This particular concha leads to this particular opening or opening of the external acoustic meatus, which takes this particular thing guarded in this particular skin fold, we call them as tragus. This tragus is an important anatomical landmark because in front of the tragus, if you put your finger, you can feel the pulsation of an artery which is lying in front of it. We call them a superficial temporal artery. During this particular examination, especially the anesthetists during this operation table, they pick up this particular pulsation in front of the tragus because they are easy to access. Most of the anesthetists sits in front of or stands in front of the patient head end. They have this access to this radial pulse is far away. That's why they take this pulsation from this particular tragus to generate whether the patient is beating or is kind of like a have or any abnormalities whenever they are doing some interventions during the surgical point of view. So this tragus and this pulsation where you're going to feel this external pulsation which is coming over here, superficial temporal artery. This is kind of like we give this particular thing for your surface marking examination. So how to identify this particular pulsation in front of the tragus and what arterial pulsation you are picking up during this particular filling over this in front of the tragus. Now, this particular helix, anti-helix over here drops down as a skin fold which is known as lobule. So, which is dropping down. This particular lobules may be united with this particular chin or maybe just like a hanging separate. They have got two or three different morphological variants are there. So, coming from this particular auricle and this particular pinna, we are going to talk about this other thing which is known as this particular tube which is known as external acoustic meatus. So this particular tunnel which is starting from this particular deepest point of this particular auricle starts over here and ends into this particular landmark which is known as the tympanic membrane. So from this particular point to this particular length we have this particular tunnel, we call them as external acoustic meatus. Now this particular external acoustic meatus, you see that it has two components. So it has two parts. It has partly made of cartilage and partly it is made of bones. So this particular component which you are seeing here is related to this particular pinna. We have this elastic cartilage. So continuations of this goes up to this particular point where you have this bone intervenes up to this region which is known as the lateral part of the external acoustic meatus is cartilaginous. And beyond that, which is entered and covered by this particular bone which is the petrous part of the temporal bone which is lying over this region which is made of the bone. So this particular external acoustic meatus is partly bony and partly cartilaginous. So we have a union point between this particular bone and cartilage, where this particular cartilage and bone union point is little bit narrowed down. That is the narrowest point of this particular external acoustic meatus. So coming back once again, so we have to know this particular morphological difference. This particular external acoustic meatus, the entire tract is made of partly cartilage and partly bony. We do not have to dig deep into up to 2/3 or 1/3 into which part is cartilaginous and which part is bony. But because during examination it's not possible to generate those informations, rather than we just keep it in our mind, it is made of cartilage in this particular lateral side and made of this bone which is on the medial side of this external acoustic meatus. Now, coming from this particular acoustic meatus which is lying over here, the important feature about here is this is lined with the skin, and this particular skin which is lining over this pinna is continued down along with this cartilaginous part of external acoustic meatus. So we have the skin which is lining thing which is known as the stratified squamous epithelium, which is keratinized. So this particular keratinized stratified squamous epithelium lining of the skin goes with this particular pinna to this external acoustic meatus till this particular cartilaginous part is there. Once it moves to the deeper part, bony part, this particular skin which is overlying this particular external auditory meatus or external acoustic meatus, which is little bit gets thinned out. So this particular skin thickness which is present on the lateral side is thicker compared to the inner side. Now what is the big catch about it? Why should we know about the skin demarcations? Demarcations of the skin important over here. We have the skin glands are there which is known as sebaceous glands, sweat glands. So this particular cuticle of the skin which is present on this external side, also known as the lateral side, which is present with lots of secretory material, that is known as the sebaceous gland secretion. We know that sebum. Many times we see that we have observed these collections of the sebum may be just like getting crusted into this particular regions, which is maybe blocking this particular region. So that's why you have to know that this particular external side of the ear or lateral side of the ear or external acoustic meatus fitted with the sebum or sebum secretion, which is coming as a wax or ear wax, which is coming on here and maybe plugging this unless these things are cleaned out. So that's the point over which you have to keep in mind in this particular region. Second thing about this particular thing, we call this particular skin and the glands which is present over here could be infected. If it is infected, this particular thing which is lying over here gets kind of like an inflammation and which becomes painful and causes some diseases. We are going to talk about it very soon. So these demarcations of the skin lining we have to know in terms of this particular clinical terms. The third or this particular medial third, that's why you're talking about the cartilaginous part and the bony part. If you cannot remember which part is contributing more and which part is less, we do not bother. Rather, more important is that we should be knowing which part is cartilaginous, lateral or medial. That entity is good enough to understand this thing. Now moving from this particular external auditory meatus, the importance over here is the nerve supply. Why is this nerve supply important? Important is because this particular region is prone to have infection. So there are two nerves which are basically supplying the skin over here, and these are nerves which is picking up the general sensation, that means touch, pain and temperature. So if this particular region is having some kind of inflammations or any kind of infections which is bothering out here, we may have this particular irritations of the skin which is leading as a pain. So what are the nerves which is carrying the pain, which is known as general pain sensation, which is supplying to this. Now if you look at here, the external side of the pinna which is supplied with a number of nerves. The auricular nerves in sense, we have the great auricular which is supplying this particular region. We have this lesser occipital which is supplying this particular region, which is kind of like taking up this particular supply over here. But more commonly or more interestingly, we are focusing in this particular canal or this external acoustic meatus, the nerve supply of it. It is supplied by two of these. One is the bottom side or this lower part of this particular canal is supplied by the branches of the vagus, which is known as the Arnold's nerve. And then we have a part of this particular skin which is supplying on the top side, which is coming from the auriculotemporal nerve, which is a branch of third cranial nerve or V3, a fifth cranial nerve or V3. So this particular demarcations we have to know. Now we have a clinical association over this particular region. Now what is a clinical association? Now once I give you a clinical case or clinical phenomenon, that makes it very much understandable what happens with this particular auricular branch of vagus nerve. Now when I was doing this rotation in our clinical life, I have a friend who was also doing this rotation with me in ENT divisions, right? So everybody is gone. We are two people. When we are doing the clinical rotation in the ENT division, everybody has moved out. We are the last two fellows treating some patients or pretending to treating some patients who had some issues in the ear and it was blocked or something. So I do not remember what. My friend let the patient stand and say, okay, let me clear these things or doing something. All of a sudden, the patient faint and fall in ground and bump his head and it's cracked. And looking at it, I didn't take any chance. I just watch the door and run away. Because I am not going to take the beating if this patient party is going to come after me and just I did these things. So I called the senior fellow who was there and say that there's a mishap which happened and please come and just come over here. He came and said that what happened. My friend said, I did nothing. Believe me, I did nothing. I only just cleaned the ear and the patient just fell down and just happened this. This particular innervations of this particular external ear and come back. So I read that and say that what nerve supplies over here? I say this nerve supplies over here is a vagus nerve and branch over here has a special name. It's known as Arnold's nerve. I say okay. He said okay, good. So what's the specialty about? As a branch of vagus it supplies, so what happens if the vagus is irritated? Now once this vagus is irritated, it can be just like an inhibitory to the heart rates. So it has a parasympathetic effect on the heart. So if the stimulations of this particular vagal branch is done over there, it leads to vagal stimulation. That vagal stimulation stops the heart and the patient faints. So it's kind of reflex thing which happens if you have this too much of irritation if you are making in this particular region, external auditory meatus region. This Arnold's branch of the vagus nerve gets irritated, which is a branch of vagus nerve. That particular vagus nerve irritation leads to cardio inhibition or skipping of heartbeat. Patient faints out and it comes back after a while, but it can create mishap. That means patient fell down and bumps his head and had cut on, etc., etc. So this matters over here. This particular tiny branch may not right now, but again, when you are intervening in your clinical life, if you are intervening in your ENT patients doing something in an external ear, it apparently looks like, okay, I'll just take it out. It's not like that. So patient may faint out because of this vagus stimulation. Always let the patient be seated in some position or else it will create some kind of trouble. Alright, so this innervation of this external auditory canal matters to us a lot about the clinical part is concerned, stimulations of this nerve. Now, again, if you have any infections in this particular region, we call them as otitis. So if the skin which has present on this region have got infections, we call them as otitis externa. Now this particular nerve, as you are seeing here, is supplied by this particular trigeminal nerve, and the vagus nerve supplies over there becomes irritable and takes the pain sensation. So this person, if you have any trouble whatsoever in this external region, this particular nerve is irritated and this particular inflammations of this external ear, we call them as otitis externa. And again they talk about this particular, which are the sensory divisions which is taking up the sensation from this region. Now if a patient have got infections on the external ear involving this external acoustic meatus or external auditory tube, so this particular tragus, if you press it, it becomes painful. So tender sign pressing over the tragus is a clinical examination point which helps you to understand if this particular inflammation have gone into this inner tube, into this particular tube or not. So this particular inflammations or infections of this particular external tube is a kind of important. So this Arnold's nerve and this particular auriculotemporal nerve which supplies to branch of V3 and this 10th cranial nerve vagus is important. Tympanic membrane will be just coming into it. So this anatomical clinical point regarding to this particular innervations is important. And what do you mean by the otitis externa, which is the external auditory tube inflammation or infections, and how these particular nerves are responsible for carrying this information from this pain, temperature sensation of over this region is a kind of important thing that we must prepare. Moving from here to these landmark boundaries, as we have mentioned, the external ear continued to this particular middle ear, and this middle ear continued to this particular inner ear. So this external ear and this particular middle ear is bounded or kind of like have a partition made by this particular membrane. We call them as tympanic membrane. This is an exam short note. We have to prepare this particular tympanic membrane for the exam short note purpose. So we have to know a little detail about this particular tympanic membrane, and moreover this clinical problem related to this tympanic membrane also surfaces in the examination. So it's a transparent oval pearly white membrane placed into this particular deepest point of the external auditory meatus, or this landmark point between external auditory meatus and this middle ear, where you see this particular membrane is placed. Is have a kind of diameter roughly by 1 centimeter, and this particular membrane is not a flat structure, is having a concavity towards this particular external side. That means it looks like a disc or a kind of radar which is catching up this particular sounds which is coming through this external auditory tube, and this particular external auditory canal which leads to this particular pearly white membrane is visible through, if you throw the light through this external auditory tube or external acoustic meatus. Now this particular tube, this particular membrane, as you seeing here, is having two layers. One is the layer which you seeing here facing this external tube, external auditory canal, and it has a other side which is facing the middle ear. So it has an external or lateral side, and it has a medial side which is facing accordingly different segments of this ear. Now this particular region which you seeing here, which is facing to this external auditory canal side, is lined by the skin. What skin? Which is lining the external auditory canal. That same skin lining this particular outer side or external side of this particular membrane. Whereas this inner side of this particular tympanic membrane is lined by the mucosa which is present on the middle ear. So externally it is lined by the skin or cuticle which is covering here. Inner side it is mucosa lining. Now as it has different linings on the external side to the internal side, the nerve innervation also different in case of the external side and internal side. So this external side which is lying over here is supplied by the same nerve that we have talked about, which is supplying this external auditory tube, the trigeminal V3, and this vagus nerve which is supplying these particular domains on the external side. From the inner side we have a different nerve which supplies to it. The inner mucosa of this particular middle ear is supplied by the branches of the glossopharyngeal nerve. So inner mucosa of this particular region have got supplied by the glossopharyngeal nerve. Now what is the importance of knowing this particular external surface supply and internal surface supply? It depends. Now if you have a patient who has the infections which is affecting this particular external auditory tube and eventually catching up the infection to the external side of the membrane, that will going to present differently than that of the patient who has this particular inflammation on the inner side of this middle ear mucosa affecting this particular inner aspects of the membrane, which is going to present clinically different with different problems. Because of these, the pain touch sensation is carried by the two different nerves from the external side to the internal sides. So that's why it matters about the knowledge of these external and internal sides innervations. Coming from here, once you divide this particular tube of this particular membrane, we have two parts to consider about this particular membrane. We have this particular membrane divided into two broad parts. A part of this particular tympanic membrane is tightly anchored. A part of this tympanic membrane is loosely anchored. So that makes this particular tympanic membrane can be divided off into two basic parts. We call them as pars tensa, which is tensely attached, and pars flaccida or flaccida, which is loosely attached. You see this particular tympanic membrane. You see that is the upper part which is lying above this particular landmark point, which is the inner ear ossicle. Beyond this particular ear ossicle, a part of the tympanic membrane, these tiny portions, maybe just like 5% of the tympanic membrane, which is hanging over this particular overlying shadows over here. This little white part, we call them as loosely attached part of the tympanic membrane. We call them as pars flaccida, which is loosely attached. And where you see the rest part, 95% of this tympanic membrane, which is anchored to this particular ear box, which is tensely attached or kind of tightly attached. We call them as pars tensa. So these are the two basic morphological parts or descriptive parts of this tympanic membrane. Apart from external side, inner side, apart from these particular different morphological or cuticular innervations, mucosal and as well as this particular external innervations that matters over here is pars flaccida and pars tensa. So these are the two entities about this particular tube which you have to know. Moreover, there is another point related to this particular auditory tube we have to understand up to here. So there are some elements which are basically plastered into this tympanic membrane. You see this particular pictures of the tympanic membrane, and into this particular tympanic membrane, within these layers of the tympanic membrane, which had got 3 layers sourced from 3 different elements. So this particular tympanic membrane into it embedded few structures. You see that there is one red structure which is lying over here. So this is an ear ossicle. In the middle ear we have some tiny ossicles present. So one of this ear ossicle we call them as malleus, which is present over here. So this handle of the malleus is basically embedded within this tympanic membrane. And this particular handle of the embedded membrane, which is going down and making a bulge point, we call them as umbo, U-M-B-O. Now this particular middle ear ossicle is embedded within this particular tympanic membrane. This is one structure that is embedded within this tympanic membrane. What does it mean? If you remove this particular tympanic membrane by any chance, this particular ear ossicles, you have to strip it off or else it will come out. So this is what we have to understand about embedded thing. Other thing, you follow this particular yellow structure. This is an important nerve which is known as chorda tympani. So this particular chorda tympani you perhaps come across when you are studying this particular cranial nerves in several locations. So this particular chorda tympani nerve crosses over this particular medial ear ossicles from 2 walls anterior to the posterior walls and growing and moving across and also embedded within this particular tympanic membrane. Now, why this particular embedded structure matters a lot. Whenever we are coming for the clinical point discussions, we have to know the precise location of this particular umbo and this malleus and as well as the chorda tympani, or else will be messed up during surgery. So this particular structure which is crossing over like the nerve and what structure is embedded within this tympanic membrane matters a lot whenever we are going to do any surgical interventions related to this tympanic membrane. And rest thing is about tympanic membrane is we already know that it vibrates, catches up this particular sound which is coming from this external acoustic meters with this vibration. This particular vibration is transmitted through this particular ear ossicles and then finally goes to the middle ear and transmitted through, it goes there. It has got 3 layers. It has got 2 outer layers, which is outer layer and inner layer. The outer layer and inner layer is innervated by the 2 different nerves which is lying on 2 different locations. Sensory supply is concerned from the outer side and inner side. We talked about that, and this particular membrane is not a flat structure, is a kind of structure. You can see that this is making an angle. It's not a straight line structure, it is not straighting, rather it is stooping forward as if it is picking up something. It is picking up the sound wave which is coming from the tube and making an angle over here and placed in this particular middle ear cavity. So this is about this particular tympanic membrane. Apart from this, the clinical point will be coming across when we are going to talk about. Now this moves us to this particular cavity space from the external ear to the middle ear. So this particular middle ear we have to know a little bit detail about it. So we have to first precisely locate where do we mean by the middle ear and how this particular middle ear is separated from the external ear and the inner ear. So we will be focusing on this particular hexagonal area of this particular of the ear. We call them as middle ear. So this is a chamber that we are seeing here is externally communicated with this external ear and bridged by this particular membrane. We call them as tympanic membrane. So tympanic membrane is basically lying between this middle ear and external ear, and this particular middle ear is separated from this particular inner ear by this particular folds. We call them as bony ossicles, which is communicating over here and ending onto this particular walls of the middle ear and communicating with this particular organ, which is known as the organ of Corti, which is lying on this particular semicircular canals, and the cochlear space, which is lying on this region. So if you look at this particular entire space, you see that this looks like hexagonal box. It has got 6 walls present on the middle ear. This is a superior wall or a roof. This is the floor, as you can see, which is related to this particular vascular structure. This is the wall which you are seeing here. We call this wall as a lateral wall. And opposite to the lateral wall, this is the medial wall, which is related to the organ of Corti or cochlea. So this wall demarcation, you have to understand very well. Then we are left with the anterior wall and the posterior wall. So this particular different walls of this middle ear, we have to understand, we have to learn. So let's go quickly about this particular wall demarcations, then we go about the content later on. So let's go into this particular cavity of this middle ear that we have to understand first, then we can understand this easier thing about this content of the middle ear. So this is what the complex part of this middle ear concerned or composed of. This is the cavity of the middle ear that we are looking at, and you have to understand these different walls, how they are placed and what are the relations of these different walls as you are seeing into it. Now this is a schematic picture once again. So you see that there is a one wall which is removed over here to given view to the interior of the middle ear. So one wall is removed here is the lateral wall. So this particular lateral wall which is present over here is covered by the tympanic membrane. Now we have removed the tympanic membrane. Once you have removed the tympanic membrane, which is basically the lateral wall, then we can see the rest of the walls. As you are seeing here, the rest of the walls. Now let's take one at a time. What are the walls you are seeing here? This is the roof. Now this particular roof which is related to the some structure that you have to know. This is the roof. If it is, then opposite to it, it is the floor which is related to it. So this is the floor side. Now this is the wall which you removed over here is tympanic membrane was sitting here. This is a medial wall. So this medial wall is removed and you are seeing exactly the medial wall which is lying opposite to the lateral wall. So the tympanic membrane which is covering this lateral wall removed, and lateral wall you cannot see anymore. You are seeing the opposite to the lateral wall which is the medial wall. That means the organ of Corti or this cochlea which is lying deep to that or beyond that wall. If you break this wall, you can see this particular cochlea or these particular semicircular canals beyond this. Now these are the two other walls. This is the anterior wall, this is the posterior wall. Posterior wall related to this bone which is known as mastoid. So this particular mastoid is on the back side. This is a small inside, this is the zoomed thing which you are seeing here. This is the back side, this is the front side. So this particular front side have got features, this particular back side of the wall have features, roof have features, floor have features, medial wall is particularly important, that also have features. Now we take at a time to describe about this particular different walls. We have some other picture as well which gives you different ideas about this, which is also a schematic picture. So this is the roof, again this is the floor, this is the anterior wall, this is the posterior wall, this grey wall which you are seeing here is the medial wall. If you break this thing, you can get the organ of Corti, and this particular wall which you are not seeing here is the lateral wall which was covered by the tympanic membrane. This is the orientation. Once you understand the orientation, it's easier for going for different wall description. So this roof of this particular middle ear cavity is related to this particular tegment tympani, which is a thin plate of bone, and beyond that we have this temporal lobe of the brain. So this roof which is separated from the brain, which is formed by this tegment tympani, a piece of bone. Coming down below, which is the floor. this particular blue structure which you are seeing here is the internal jugular vein. So the internal jugular vein which is having a dilatation, so we call them as bulb of the internal jugular vein which is related to it. So this is the floor which is related to it, and this particular floor is pierced by a branch of glossopharyngeal 9th cranial nerve which pierces through, gets into it. So this is the floor side. This wall is easy again, this have got features. This is the anterior wall. Anterior wall is related to two structures, one muscle which is coming above and one tube which is coming below. This tube which is, we call them as tensor tympani. So this tensor tympani and the auditory tube which is coming here with the anterior wall. Take to the posterior wall, the mastoid bone which is lying here which has a cavity, we call them as mastoid antrum, and this particular mastoid antrum which is communicating with this particular middle ear through a door, we call them as mastoid antrum which is communicating on this side. So this particular mastoid antrum which is related to this part communicating with this mastoidal ear cell which is lying on the posterior side, and this bottom side you can see that there is a nerve which is coming down on the back side which is a facial nerve getting into through the foramen which is known as stylomastoid foramen which is lying between this mastoid process and the styloid process which is hanging between them. So we have the stylomastoid foramen which is lying there. So you see the facial nerve which is getting down from this particular canal, we call them a facial canal, getting out of this particular, this opening which is known as the stylomastoid foramen, getting into the parotid substance and supplying to this particular different areas of the face. So this is how it is related to it. So this brings us this more clarified picture about this particular middle ear cavity and the different wall architecture. These are our exam questions which you see that these are the long exam questions. So this particular areas we have to know. This is a roof formed by the bone plate, we call them as tegmen tympani. What lies on top of it is a brain matter which is lying on top of it. If this is the floor which is related to this particular internal jugular vein. The internal jugular vein over here sees that this particular plate is pierced by a nerve which is known as tympanic branch of glossopharyngeal nerve getting into the middle ear cavity. So it is coming over here. Then we take this anterior wall which is related to two tube structures, one muscle, one tube. This particular muscle which is getting here we call them as tensor tympani muscle. Below here we have the auditory tube which is getting in here and attaching with these nasopharynx which is opening into here. So these are the four walls we are talking about. Now talking about the back side. This back side we have an opening. We call them as antrum for the mastoid communications or mastoid air cell communication which is communicating on the back side, and it is related to the downward portions of the facial nerve which is exiting through the brain getting down. We call them as facial canal which is having kind of oblique part and the vertical part. You see the vertical part is going in down. Now as you see that this is a facial nerve which is coming down. It shoots two nerves which pierces the posterior wall. One nerve which is going to pierce over here. This is the first nerve which is known as nerve 2 stapedius, and then it pierces or gives another branch which is known as chorda tympani. And we talked about the chorda tympani which is embedded within this tympanic membrane. So the chorda tympani comes from this posterior wall of the middle ear which is related to the mastoid, runs through the middle ear cavity, pierces the anterior wall and gets out of this particular anterior wall and gets into the substance of the head and neck region. While it is crossing over from the posterior wall to the anterior wall, it is embedded in the tympanic membrane. Of this, we are left with this particular area which is known as this medial wall. The medial wall itself could be your exam question because it has got features which is related to it. So this particular medial wall, as you can see, have got three basic features to identify. This has a bulge over here which is caused by the semicircular canals in this cochlea which is making a bulge over here. We call them as promontory. So this particular promontory is a bony spicule or bony bulge. Into this bony bulge we see that the tympanic branch of glossopharyngeal nerve makes a plexus. This plexus we call them as tympanic plexus. Now that's why this glossopharyngeal nerve is growing over here and supplying the mucosa of entire this middle ear cavity. This is one feature which is present in the middle ear. Then we see that posterior to it we have one opening above, one opening below. So this particular opening which you seeing here is known as oval window, and which opening which is lying posteriorly but below we call them as a round window or round opening. So these two openings are got features which is present in here. The oval window is overlaid by some bones, we call them as stapes, and this round window is covered by another membrane, we call them as secondary tympanic membrane. So these features which is related to this particular medial wall is your exam question. We have to give a schematic picture of the medial wall, describe it. Describe what do you mean by the promontory which makes a bulge, do you mean by this particular oval window, what is lying on the oval window, foot plate of the stapes resting on it, round window which is known as fenestra cochleae which is occupied by a membrane which is known as secondary tympanic membrane. And these particular features which you are seeing here in the medial wall, as you are seeing here in this particular pictures over here, could be your exam part of questions which is related to it. So these features from this box to box, wall to wall over here, seeing here these two openings and this promontory and these features which is happening over here is tympanic membrane, how it is coming over here, it could be your exam questions. So this all the walls or all the features of this particular different walls of this tympanic cavity, also known as this middle ear cavity, is important. It could be your exam broad question, could be split down. So talking about the roof, what are the structure related to the roof? Talking about the floor, which is the structure related by to it, and what nerve pierces through it. So this roof and floor, once you are done here, then you can move to this particular medial wall which is having got these particular features that we have already mentioned with these pictures or schematic pictures. Then lateral wall is a tympanic membrane. Anterior wall, as you can see, this is related to one muscle which is on the top side which is known as tensor tympani. Then we have the auditory tube which is related to it. Posterior wall which is on the back side is related to the opening which is related to this particular mastoid air cell. Mastoid air cell editors are opening to it. And then vertical part of the facial canal which pierces and gives two nerves, nerve to stapedius and chorda tympani. So these two elevations or these two important structures which is related to is very important. We do not want very detailed description of it. We just ask you about this one liner, two liner things about it, these particular entities. So superior wall which is roof, floor, and this anterior posterior wall, the medial wall in detail about this particular openings and this complex things related to this like a promontory and this nerve plexus which is related to it is a kind of very important entity which you have to know, and along with that tympanic membrane itself could be your exam questions. Now coming from this particular descriptions of the box, quickly go into this particular contents of this particular middle ear. So into this particular middle ear we have number of content. We have some bones which is related to it, we have some muscles which are related to it, we have some nerves which you already have seen. So bones, the middle ear, there are tiny bones, we call them as ear ossicles, malleus, incus and stapes. They are present in this particular middle ear cavity as a content. We have two sets of muscles, they are related to it, we call them as stapedius and tensor tympani. Tensor tympani is coming from this anterior wall which you have seen related to the eustachian tube. Stapedius is related to the posterior wall which is lying on this particular side and related to this particular stapes then. So this stapedius, the nerve supply of the stapedius is important and it is supplied by the facial nerve which is the cranial nerve 7, and this tensor tympani which is supplied to them is important which is related to it, and the nerves itself which is present in the middle ear, we have to know about the chorda tympani which is an important branch. And then we have to know about the tympanic plexus which is a branch which is formed over the glossopharyngeal nerve which is making a plexus out there. These are the two nerves, branch of things which is related to this particular content of this particular tympanic of the middle ear tympanic cavity or middle ear cavity. So this is the nerve, these are the small ossicles, ear ossicles, how they are present and how they look like. This is the stapes that we are talking about. The stapes looks like a stirrup. As you can see, the stapes is related to this part, we call them as foot plate of the stapes. This foot plate or base of the stapes is resting on the oval window which is related to it. And then we have another bone, ear ossicle, which is known as malleus, which is related to ear. This malleus we referred here. It looks like this particular club shaped structure. This malleus is anchored or embedded into this tympanic membrane that we have mentioned about this particular ossicles which is related to it. So these are the things related to this particular entities about this particular muscles. Now about these muscles, these two muscles which is related to the ear ossicles or the middle ear, tensor tympani, and this particular stapes which is innervated by the V3 and the 7th cranial nerve. The functions of these particular muscles is that to protect this particular tympanic membrane when we are exposed to the high pitched sounds. So all of a sudden, if you are suddenly exposed to a sound vibration which is a very high pitched, this particular tympanic membrane vibrates too much and may rupture. And this particular rupture is because of this particular ear ossicles are related to that, and this particular bones may just like hurt this particular membrane and lead to rupture of this. So that this particular ear ossicles do not hurt this particular tympanic membrane when we are exposed suddenly to the high pitched sounds, this muscle reflexly pulls it and takes this particular ear ossicles off the tympanic membrane. So the reflex contraction simultaneously of these two muscles, tensor tympani and the stapedius, helps to protect this particular inner ear for bursting out from this noise, as well as helps to prevent this or survives this particular the auditory or this tympanic membrane. So this is how you can see that the two muscles are anchored to it. This is the anterior wall. We have this tensor tympani muscle coming out and making a loop and getting anchored into this particular malleus. This is the malleus which is anchored to this tympanic membrane, and you are looking from this particular medial wall. The handle of the malleus, this particular tensor tympani is anchored to. Whenever this particular muscle contracts, this thing pulls back or moves back. The same thing over here, you see that this is a tiny muscle coming from the posterior wall which is known as the stapedius, anchored to the foot plate or a handle of the stapes which is lying on these particular parts. So whenever this particular muscle is contract, this particular foot plate it lifts off, so that this particular sound which is supposed to come back through this particular ear ossicle is interrupted, and this sound doesn't reach to this inner ear and do not disrupt this particular tiny delicate the organ of Corti structures. So this is a kind of preventive mechanism which is present in the middle ear, which is by this particular presence of contraction of these two muscles works over here. So this is in short about this particular walls of the tympanic cavity. Again, middle ear cavity also known as tympanic cavity. Many a times we see that we prepare this as a middle ear cavity and we do not reflect the name about this tympanic cavity. So in an examination they say that detailed discussions about the walls of the tympanic cavity, and sometimes we get clueless about what do you mean by the tympanic cavity. We never heard of this. The other name of the tympanic cavity is the same middle ear cavity. So this particular roof, floor, walls of the middle ear cavity that you have to understand, that you have to know really well, and along with the features especially emphasizing on this particular middle ear, promontory plexus of this glossopharyngeal nerve and this oval window and round window, and what are the things that is covering to them, they are very important. Now we are moving to the last entity about here, which is known as the eustachian tube or the auditory tube. Now partly we have discussed about this auditory tube. This is a kind of tube which is related to the anterior wall of this particular middle ear or tympanic cavity and goes down, which is communicates with this nasopharynx. Behind this inferior concha it is opening on. Again, this particular auditory tube or eustachian tube is partly made of cartilage, partly made of bone. You see that the deep side which is present, or the inner ear which is made on this particular region, which is bony, and this side which is related to this particular nasopharynx is made of cartilage. So partly bony, partly cartilaginous. The flip is that this particular inner side which is lying over here, the medial aspect which is opening into nasopharynx is made of cartilage, and this particular exterior side which is related to the ear or middle ear which is made of the bone. So partly bony, partly cartilage which is covering to it. This is what is lying here. So this particular tube is communicating with the middle ear with these nasopharynx or lateral wall of the nasopharynx. What are the functions of the tube? This particular tube is basically making the air pressure equilibrium between this particular chambers of this particular middle ear. So this inner ear, this middle ear chamber pressure remains settled because of this particular tube patency. If this particular tube is by somehow is not patent, we have this particular middle ear is at stake because this particular pressure inside to it drops down, and that leads to problem. We'll talk about it. So this particular tube, as you are seeing here, it has a lining mucosa or lining epithelium which is lying over there. So the mucosa which is lying over here is the same continuation of this particular middle ear mucosa. So middle ear mucosa is innervated by the glossopharyngeal nerve. The same Eustachian tube mucosa is also supplied by the glossopharyngeal nerve principally, except this particular region which is at the opening side at the nasopharynx, which is innervated by this trigeminal nerve. So this tube which is communicating into this particular region is having some kind of importance. There is a mechanism which keeps this particular tube open. So we call them as patency of the tube is important, because by any chance if this particular tube is blocked, we have this particular air which was present inside this tympanic cavity will be absorbed, and there will be negative pressure created inside. So that we do not want to have. So we want to keep this particular tube or Eustachian tube patent. So what keeps this particular tube patent? There are things which is anatomical thing which keeps this open. One thing, bone and cartilage, it's still non-collapsible structure. They keep these things patent. But by any chance, if this particular opening, if it is blocked or kind of obstructed, that can happen. So to keep this particular thing or tube open, we have a number of muscles which is related to the soft palate that contract. We talked about the muscles of the soft palate, tensor veli palatini, levator veli palatini. Those are the salpingopharyngeus. Those are the muscles which is related to the pharynx, related to the soft palate. They contract. So these particular contractions of these particular muscles, along with this tensor tympani, they keep this particular tube patent. By any chance, if this particular tube is blocked, the air is sucked out. So you can imagine if you have this particular thing, which is air is negative pressure over here, that leads to this tympanic membrane further pulled back into the inner side. That means the tympanic membrane is retracted. We call them as retractions of the tympanic membrane. That means stretching inside of the tympanic membrane. If you have the stretching inside the tympanic membrane, the mucosa which is present inside this region will be irritated. That means the glossopharyngeal nerve will be irritated accordingly and will be paining accordingly. So if we have this particular retractions of the tympanic membrane, we will have the ear pain. That ear pain which is coming from the middle ear will be carried through the cranial nerve number 7, glossopharyngeal nerve. This entity that you have to keep in mind regard to this. Other thing about this particular tube direction. So when we are young, this particular tube was short and this particular tube was straight. So we see that there is a curvature between the bony part and the cartilaginous part. In case of the young, this curvature was not there and it was a straight tube. So you can see that nasopharynx, which is a number of the lymph nodes which is present to it. We have the adenoids, we have the tonsils, we have the mucosa which is related to it and which is prone to have infections, especially the kids. So the kids, if they have the infections of the nose, allergic rhinitis or any kind of infection of the nose or throat, can pass through this particular tube to the middle ear and can infect this particular middle ear mucosa and can lead to a disease. We call them as otitis media. So if this particular infection goes in here and infects this middle ear cavity or tympanic cavity, we call them as otitis media, which is a kind of disease condition. Now, you have a otitis media, you have diagnosed it, and you are saying that we are treating it, or if you are not treating it. So if the infection settles over here in the middle ear, that particular infection, if it is not treated, can lead to accumulation of pus or abscess formation. So then we have a fluid inside this middle ear. So if you have a fluid in the middle ear where this Eustachian tube is transmitting and then it is blocked, this particular fluid stays inside this particular middle ear cavity. So that particular middle ear cavity fluid, we call them as middle ear cavity abscess. So this particular middle ear cavity abscess is a dreadful thing, because if you are not draining that particular fluid out of the middle ear, it's going to ruin this ear ossicle, you're going to ruin this particular conductive things, and it's going to ruin the other structures which is related to it. So we have to drain it out if you have infections like abscess which is present to it. Now, if you have an abscess to it and blocking this thing has created this, and this particular tympanic membrane will be bulged out. So, bulging of the tympanic membrane happens when, and retractions of the tympanic membrane happens when, and what are the disease that underlying to it, you have to figure it out looking at the tympanic membrane. And this clinical knowledge keeps you superior ahead of other people, whether you can judge this clinical problem of the individual or not. So, if you have a retractions of the tympanic membrane, that means tympanic membrane is pulled inside, there is no fluid, it is dry. Now, if the tympanic membrane is bulged out, how we are going to see the tympanic membrane? From this external side. So, if it is bulged out towards you, if you are looking at it, that means you have something collected inside. So, bulging of the tympanic membrane is a disease, and retractions of the tympanic membrane is another disease, and you have to decode that in a clinical setting. Now, coming back to this particular clinical thing, we call this a clinical term as myringotomy. Now, what is a myringotomy? We have a fluid accumulation within this particular tympanic cavity or inside this. That means it has an abscess. Now, you are going to treat this patient. Now, how you are going to treat this patient who has an abscess inside beyond this particular membrane? The tympanic membrane is bulged out to the exterior side, and it has a fluid which is present inside. So, how we are going to treat that? That particular treatment which is involving here, we call them as myringotomy. That means you are going to cut this tympanic membrane. You are going to cut this tympanic membrane. Once you cut that, that particular fluid which was present inside the middle ear cavity will come out. Now, my question is, this is a tympanic membrane given here. Where you are going to cut that tympanic membrane? Now, which quadrant you are going to cut? So, you remember that the locations of administering intramuscular injections in the gluteal region. So, how do you give intramuscular injections in the gluteal region? Put in to what location you are piercing that needle? Upper outer quadrant. Now, taking that same thing, upper outer quadrant, if you are administering this intramuscular injections, if you have to pierce this, the tympanic membrane, which quadrant you are going to pierce? There are 4 quadrants: upper outer, upper inner, inner outer, inner ear, or lower. Like you draw a line like this and get the segments. So, this is your tympanic membrane, you have 4 quadrants, and which quadrant you are going to pierce or cut to drain the fluid out, which is known as myringotomy, and why? So, this covers this topic.
Is a type of methods or practice by which we can prevent the production of ovum, production of your, or sorry, it is a fertilization of ovum. ওভামটাকে ফার্টিলাইজ করতে না পারে, ইট ইজ এ ব্যারিয়ার মেথড, তাই না? ওয়ান টাইপ অফ ব্যারিয়ার মেথডস। তো হোয়াট আর দ্য contraception we looking at? Contraception we looking at is a physiological method and in the pharmacological method. So start with the physiological. Name one physiological method where the contraception not required. During lactation, because you, when we suck, there is a sucking reflex, you know, it stimulate the hormone like LH, and there is a negative feedback over there to release the less amount of GnRH, gonadotropic releasing hormone. So because of there is a less amount of secretion of gonadotropic, right? GnRH নিচে নামছে, সেখান থেকে দুটো ভাগ হয়ে যাচ্ছে, FSH অ্যান্ড LH। LH তারপর এক করছে কোথায়? ইন দ্য ওভারি, তাই না? তাই তো পড়েছি আমরা হরমোনে, এই ওই ক্লাসটা আমি নিয়েছিলাম তোদের। তো আমি যখন LH সিক্রেশন, সাকিং রিফ্লেক্স হচ্ছে, LH বেশি বেশি করে বেরোচ্ছে, সে কি করবে? দ্যাট ইজ এ নেগেটিভ ফিডব্যাক ওভার pituitary and hypothalamus to less secretion of GnRH, and there is a less secretion of GnRH, there is a less amount of ovulations। ঠিক আছে, কদিন থাকে? Generally 6 to 8 months after delivering of the baby, 6 to 8 months it is the normal periods of your it is a term called ল্যাকটেটিং অ্যামিনুরিয়া। এই টার্মটাকে ব্যবহার করা হয়, ল্যাকটেটিং অ্যামিনুরিয়া। ঠিক আছে, বিকজ এই সময় কোনো মেন্সও হয় না। মেন্সটা হবে কী করে? ওভারির উপর তো নেগেটিভ ফিডব্যাক আছে, ওই মেন্সটা হবে না, দ্যাট ইজ কল্ড ল্যাকটেটিং অ্যামিনুরিয়া। তাহলে এর অ্যাডভান্টেজ কী আছে? অ্যাডভান্টেজ হচ্ছে কোনো কিছু লাগছে না, নর্মাল ন্যাচারাল। ডিসঅ্যাডভান্টেজ কী আছে? রেস্ট, তোর লেস রিলায়েবল মেথডস। তোরা যখন পরবর্তীকালে ওয়ার্ডে যাবি তখন দেখবি দুটো বাচ্চার মধ্যে বয়সের ডিফারেন্স অলমোস্ট তোর ওই 1 বছর 2 মাস 3 মাস এরকম, 4 মাস এরকম বয়স দুটো বাচ্চার মধ্যে ডিফারেন্স। তাহলে কী হচ্ছে? হিসাব মতো একটা বাচ্চা হচ্ছে 9 মাস, যদি 8 মাস কন্ট্রাসেপশন থাকে, 6 মাস, 6 থেকে 8 যেটা বললাম, তাহলেও কত হচ্ছে? অলমোস্ট 1.5 বছর। তাই কিন্তু তোর কি করছিস? এটাতে দেখা যাচ্ছে বাচ্চার বয়স হচ্ছে, দুটো বাচ্চার মধ্যে বয়স, অনেকে বলবে 1 বছরের পার্থক্য। তাহলে 1 বছর কী করে হলো? তার মানে কি? তার মানে ওইখানে গন্ডগোল হয়েছে কিছু একটা। ঠিক আছে, সো এটা হচ্ছে ডিসঅ্যাডভান্টেজ, লেস রিলায়েবল মেথডস। বোঝা গেল? তোর ফিজিওলজিক্যাল মেথড, ফিজিওলজি পড়তে এসছিস, ফিজিওলজি মেথড তো থাকবেই, তাই না? তো what are the physiological methods? Physiological method হচ্ছে there is a call safe, so safe period and one call unsafe period. What is the safe period? Safe period হচ্ছে first 7 days and last 7 days, that is called safe period. In between 15 days it is the unsafe period। ঠিক আছে, এবারে হচ্ছে তোর, তাহলে আমরা কি হতে পারে? অ্যাডভান্টেজ কী হতে পারে? অ্যাডভান্টেজে ওই সময় কিছু লাগছে না। ডিসঅ্যাডভান্টেজ কী হতে পারে? ডিসঅ্যাডভান্টেজ হতে পারে হচ্ছে তোর মেন্সের তো কোনো টাইম হয় না, কারো 28 দিনে হতে পারে, কারো গিয়ে 30 দিন হতে পারে, কারো এগিয়ে গিয়ে 22 দিনে হতে পারে। জেনারেলি আমরা ধরি অ্যাভারেজ হচ্ছে 28 ডেজ, কিন্তু ম্যাক্সিমাম ক্ষেত্রে দেখা যায় যে বিভিন্ন এখন যে ম্যাক্সিমাম মেয়েদের কী হয়? PCOD মানে পলিসিস্টিক ওভারি। তো দেয়ার ইজ এ হিউজ অ্যামাউন্ট অফ ডেজ ডিফারেন্স, কারো এগিয়ে গিয়ে 20 দিনে 22 দিনে হচ্ছে, কারো পিছিয়ে গিয়ে তোর 1 মাস পরেও হচ্ছে। সো তাহলে কী হচ্ছে? ডেট ক্যালকুলেশনে গন্ডগোল হয়ে যাচ্ছে, অ্যান্ড দেয়ার ইজ এ চান্স অফ ফার্টিলাইজেশন। এটা ডিসঅ্যাডভান্টেজ। বোঝা গেল? মানে হোয়েন দ্য সিমেন not deposited in your vagina। অ্যাডভান্টেজ কি হচ্ছে? অ্যাডভান্টেজ হচ্ছে তোর কিছু লাগছে না, হ্যাঁ। আর ডিসঅ্যাডভান্টেজ কি হচ্ছে? ডিসঅ্যাডভান্টেজ হচ্ছে বিকজ ইউ নো ওয়ার our sperm count in million, not in 100, not in 1000, and to fertilize a ovary only one sperm required, তাই না? একটা স্পার্মই দরকার হয় ফার্টিলাইজ করতে, বাট উই প্রডিউস দ্য মিলিয়নস। তো ইউ নো দ্য একটা মানে দ্যাট ইজ এ when we count in million and in one, so there is a huge risk, no? When we produce million, though we withdraw it, because per drops it is million, so when we that is count we are million and need only one sperm, so it is very unsafe method, okay? And this is the withdraw method. থার্ড কি হচ্ছে, থার্ড হচ্ছে তোর অ্যাবস্টিন্স মেথড। অ্যাবস্টিন্স মানে হচ্ছে কি কিছুই হলো না, বাট দ্যাট ইজ থিওরিটিক্যালি নট পসিবল। ঠিক আছে, সো দিস ইজ দ্য ওয়ে উই ক্যান ইউজ the physiological methods. All are physiological methods. Okay. Next we come to the pharmacological method. What is the pharmacological method? Pharmacological method means there is a device and there is a tablets. Tablets, there is a there is first start with the estrogen. So there is a estrogen pill, progesterone pill, there is a low dose pill, and there is a emergency contraceptive. ঠিক আছে, তাহলে maximum pill we need, that is the maximum pill we use, it is called the low dose pill. Because why we not use the high dose pill? Because there is a there is so many advantage in your high dose pill, hormonal. All are hormonal pill. There is some estrogen, there is some progesterone pill. ঠিক আছে, তাহলে কি হচ্ছে না, এই পিলগুলো তোর হাউ ইট তোর যেটা বলছিলাম আগে, সেটা হচ্ছে হাই ডোজ পিলের কী কী ডিসঅ্যাডভান্টেজ আছে। ফার্স্ট হচ্ছে তখন তোরা কমিউনিটি মেডিসিন করতে যাবি, তখন তোরা যখন দেখবি অনেক ওষুধপত্র নিয়ে যেতে হয়, পেশেন্টকে বাড়িতে বাড়িতে দিতে হয়। তো হোয়েন ইউ অ্যাডভাইস আ পিল, দেয়ার ইজ you must taken history and examination before prescribing any pill. কি কি তোর হিস্ট্রি নিতে হবে, হিস্ট্রি অফ হেডেক, বিকজ পিল ইনডিউস হেডেক ইট ইজ মোস্ট কমন। ওকে, তো পিল ইনডিউস হেডেক, তো ফার্স্ট হিস্ট্রি নিতে হবে তোর হেডেক। সেকেন্ড হিস্ট্রি কি নিতে হবে, সেকেন্ড হিস্ট্রি দেখতে হবে তোকে কাফ টেন্ডারনেস দেখতে হবে, কাপটাকে টিপে দেখতে হবে টেন্ডারনেস আছে কিনা। বিকজ when we use the high dose of hormonal pill, there is a more likely to chance তোর thrombus formation in our dependent part. So to exclude the thrombus formation, you always check the cuff tenderness before prescribing a oral contraceptive pill. বোঝা গেল? যখন বড় বড় গাইনোকোলজিস্ট হয়ে যাবি তখন তো দেখি ওষুধ লিখে দিবি, সেটা না। যতদিন তোর MBBS পর্যন্ত আছে ততদিন কিন্তু নিজেকে সেফ থাকার জন্যে when you prescribe a pill, always take a history of headache and check the cuff tenderness to exclude any kind of your thrombus or the disease. Because thrombus formation যদি থাকে, তুমি যদি পিল দাও, there is a increased chance of thrombus formation. Okay, so cuff tenderness, you always exclude the cuff tenderness because it is the most prominent site. ঠিক আছে, most prominent site to exclude the thrombus formation. নেক্সট হচ্ছে তোর পিল কখন তুই ব্যবহার করবি। ঠিক আছে, পিল কখন ব্যবহার করবি, পিল হচ্ছে ম্যাক্সিমাম পিল আমরা ব্যবহার করি স্টার্ট উইথ দ্য days 5 or days 7 to 21 days. ঠিক আছে, তাহলে আমরা শুরু বলি যে মেন্স যেদিন শেষ হবে সেদিন থেকে শুরু করবে, তারপর থেকে 21 ডেজ খাবে। তাহলে 21 আর 5 26, 28 দিনের মেন্স হয়ে গেল, তো পুরোটাই কভার হয়ে গেল, তাই তো। 5th ডে মেন্স আমার জেনারেলি 4th ডে থাকে, জেনারেলি 5th ডে পর্যন্ত কন্টিনিউ হয়। তাহলে আমরা শুরু করছি 5th ডে থেকে, তারপর আমরা 21 দিন খাচ্ছি, তাহলে ইট ইজ কভার হচ্ছে অলমোস্ট 26-27 ডেজ, আর 28 ডেজে মেন্স হচ্ছে। পিলসের এগুলো হচ্ছে তোর হরমোনাল কন্ট্রাসেপটিভ। নেক্সট স্টার্ট উইথ দ্য ব্যারিয়ার মেথডস। দেয়ার ইজ এ 3 kind of barrier methods. One is the your condom, second is the female diaphragm, that is the male version of condom, and third it is your the T-tube or copper loop. That is the 3 things we used. So first start with the condoms. It is readily available in your use, and it is type of barrier method that prevent the enter of your sperm into the female genitalia. হলো ডিসঅ্যাডভান্টেজ কি হতে পারে? ডিসঅ্যাডভান্টেজ হচ্ছে ফার্স্ট হচ্ছে কস্ট, তাই না? যে লোকটা গ্রামে মাঠে চাষ করে তাকে যদি লিখে দিস যে কন্ডম লিখে দিলি, যে স্লিপ 5 টাকা 7 টাকা করে কিনবে, সে কিনবে না কিনবে না, হয়ে গেল, গল্প শেষ। সেকেন্ড, in low class that is the price, and high class it is the latex allergy. Only the so many in your gynecology wards, you know, the so many patients comes with the allergy, that is called the latex allergy, because ye condom e je ব্যবহার করা হয় material je latex er, and that is the latex allergy in female, it is more common. So when there is a latex allergy in female, you can't use a condom because of allergy. তা সবসময় ওখানে ওই একটা ডিসকমফর্ট হচ্ছে, বার্নিং সেন্সেশন হচ্ছে, তাই না? তো তুমি তাকে যদি কন্ডোম ব্যবহার করো, সে নেবে না। তো দ্যাট ইজ দ্য ডিসঅ্যাডভান্টেজ কন্ডোম। নেক্সট দ্য ফিমেল ডায়াফ্রাম, দ্যাট ইজ দ্য মেল ভার্সন অফ কন্ডোম। কিছুই না, এরকম একটা থাকবে, এরকম একটা লুপ থাকবে, লুপের নিচে এরকম একটা থাকবে, এটা জাস্ট ইনসার্ট ইনটু দ্য ইয়োর ভ্যাজাইনাল, এটা রিংয়ের মতো চেপে থাকবে। অ্যাডভান্টেজ, তোর যারা অনেক মেল পার্টনার হয়, দে আর not use but not comfortable with the condom, or there is some reluctant to use condom, any reason, so you can use the female version. Okay, so female version, that is called diaphragm. Okay, next হচ্ছে তোর কপার টিউব। কপার টিউব কি হচ্ছে? কপার টিউব হচ্ছে, দেখবি তোরা যখন তোর কমিউনিটি মেডিসিনে যাবি তখন দেখবি পাওয়া যায়, কিছুই না, এরকম একটা টিউব, এখান থেকে এরকম থাকে, এটা হচ্ছে লুপ। ঠিক আছে, তুই কি করছিস? দ্য কপার টিউবটা তুই ইউটেরাসের মধ্যে ঢুকিয়ে দিচ্ছিস, তাহলে কি হচ্ছে? তিনটে জিনিস হচ্ছে। একটা হচ্ছে, অ্যাজ ইট ইজ আ ফরেন বডি ইন ইউর বডি, ফরেন, তাহলে বডি কি করে প্রথম ওটাকে বার করে দেওয়ার চেষ্টা করবে, তাই তো? তুই যদি কোনো ফরেন বডি কোনো জিনিস আমার বডিতে পুশ করিস, তাহলে আমরা কি হয়, বডির ফার্স্ট রেসপন্স কি হবে? দ্যাট ইজ টু এক্সপাল ইট। তার জন্য কি হবে? দ্যাট ইজ ইনফ্লামেশন। ফার্স্ট থিংস ইট ইনফ্লামেশন। তাহলে কি হচ্ছে? দেয়ার ইজ এ ইনফ্লামেশন ইন ইয়োর endometrial area, endometrial sites. তাহলে endometrial site এ যদি ইনফ্লামেশন হয়, কি হবে? there is a thickening of endometrium, and there is a change of environment in the endometrial cavity, and that become hostile to our sperm, and that environment, it is hostile of our sperm. তাহলে কি হচ্ছে? স্পার্ম ওখানে গিয়ে তোর আর এগুতে পারছে না, বোঝা গেল? তো দ্যাট ইজ দ্য অ্যাকশন অফ কপার টিউব। কপার টিউবের অ্যাডভান্টেজ কি আছে? কপার টিউবের অ্যাডভান্টেজ আছে তোর, তুই মোটামুটি তুই প্ল্যান করলি যে আমি এবারে বাচ্চা নেব, তো কি হবে? বার করার পর মোটামুটি দেখা গেছে যে 3 মাস পর তোর প্রেগনেন্সি অ্যাজ ইকুয়াল অ্যাজ নর্মাল। ওটা বার করা 3 মাস পর নর্মাল ফিমেলের যা তোর ফার্টিলিটি চান্স, বার করা 3 মাস পর ওই পেশেন্টেরও সেম ফার্টিলিটি চান্স। সো ইট ইজ দ্য, এটা হচ্ছে তোর মানে গ্রামে গঞ্জে এটাই টিকে আছে আর কি, বুঝলি তো? কারণ বিনা পয়সায় পাওয়া যায়, তোর গেলি, আর এটা হচ্ছে ওপিডি প্র্যাকটিস। তুই যাবি, যারা ঢোকাতে যাবে ঢুকিয়ে দেবে, আর ওখানে ওই যে লুপসগুলো আছে ওটা টেনে বার করে নেবে, ঠিক আছে? দ্যাট ইজ দ্য, কোনো ব্লিডিংও নেই, কিছুই নেই, যতদিন রাখলি ততদিন থাকলো, ঠিক আছে? এগুলোর কিছু এখন আপডেটেড ভার্সন এসছে, এগুলোর কিছু মানে দ্যাট ইজ এ কল তোর লিভোনরজেস্ট্রল বলে একটা তোর সাবস্টেন্স লিভোনরজেস্ট্রল, সেটা কন্টেনিং তোর কন্টেনিং ওই যে তোর টিউব পাওয়া যাচ্ছে এখন, মানে তোর দুটো কাজই করে দিচ্ছে, একটা হচ্ছে তোর ওই ইনফ্লামেশনের কাজটাও করে দিচ্ছে, অ্যান্ড দে অলসো সিক্রেটেড দ্য স্মল অ্যামাউন্ট অফ দ্য হরমোনাল কন্ট্রাসেপশন অলসো, মানে এর মধ্যেই লিভোনরজেস্ট্রল দেওয়া আছে, বুঝতে পারলি? তো সেটা কি হচ্ছে বাই স্লো রিলিজ সিক্রেশন হচ্ছে, তাহলে দুটো কাজই তুই পাচ্ছিস, একটা হচ্ছে ওই ইনফ্লামেশনের কাজটাও করে দিচ্ছে, আর ওইটা দিয়ে তোর ওই পার্টটাও করে দিচ্ছে, তোর হরমোনাল পার্টটাও করে দিচ্ছে, বোঝা গেল? এটা হলো তোর দ্যাট ইজ দ্য 3 মেথড উই ক্যান ইউজ। হ্যাঁ, আর তোর এমনি বাকি তো হরমোনাল কন্ট্রাসেপটিভের মধ্যে তোর যেগুলো ইস্ট্রোজেন বা প্রোজেস্টেরন, এগুলো এগুলো তো জানিস তো, এগুলো মেনলি কি করে, ইস্ট্রোজেন প্রোজেস্টেরন তুই হরমোন যখন দিচ্ছিস তো হরমোনের ওই পার্টটা বেড়ে যাচ্ছে, তাহলে নেগেটিভ ফিডব্যাক হচ্ছে গোনাডোট্রপিক হরমোনের উপর কাজ করছে, জিএনআরএইচ সিক্রেশন কমিয়ে দিচ্ছে, 1 নম্বর। আর 2 নম্বর হচ্ছে ওগুলো এন্ডোমেট্রিয়ালের উপর কাজ করে, দেয়ার ইজ এ থিকেনিং অফ এন্ডোমেট্রিয়াম, এগুলো এই পার্টগুলোই কিন্তু ওরা কনসিডার মেকানিজম অফ অ্যাকশন, এগুলি মানে জিএনআরএইচ সিক্রেশন কমাচ্ছে, এন্ডোমেট্রিয়ালকে ঠিক করে দিয়ে সেটা তোর হস্টাইল করছে, দ্যাট ইজ দ্য মেকানিজম অফ অ্যাকশন অফ ওরাল কন্ট্রাসেপটিভ পিল। নেক্সট হচ্ছে এমার্জেন্সি কন্ট্রাসেপটিভ। এমার্জেন্সি কন্ট্রাসেপটিভ কি হচ্ছে এখন যেগুলো সেগুলো হচ্ছে তোর এই ধর কোনো বাই চান্স দ্যার ইজ এ সাম ইস্যু রিগার্ডিং breaking of contraceptive, or there is a some not use it, but most important it is in rape case, so that is just called the emergency contraceptive. Emergency contraceptive কিছুই না, যেগুলো নর্মাল কন্ট্রাসেপটিভ তার থেকে ইনটু 3 ডোজে দেওয়া থাকে, মানে 3 টাইম হায়ার ডোজে এমার্জেন্সি কন্ট্রাসেপটিভ দেওয়া থাকে, ঠিক আছে? সো তার নিয়ম কি হচ্ছে, নিয়ম হচ্ছে ইউ শুড টেক উইদিন 72 hours after your exposure, 72 hours এর মধ্যে কিন্তু ওটাকে ইউজ করতে হবে, নাচেত কিন্তু ওটা কাজ করবে না, ঠিক আছে? তো নেক্সট হচ্ছে তোর কপারে অসুবিধা কি হচ্ছে, কপারে একটা অসুবিধা হচ্ছে, সেটা হচ্ছে তোর দেয়ার ইজ এ কল ব্রেক থ্রু ব্লিডিং। অনেকের সময় কি হয়, অনেকের সময় কপার অ্যালার্জি হয়, বা দেয়ার ইজ এ নন অ্যাকসেপ্টেন্স, দেয়ার ইজ সাম ইস্যু রিগার্ডিং দ্য ব্রেক থ্রু ব্লিডিং। তাহলে এগুলো হচ্ছে তোর ফার্মাসিউটিক্যাল মেথড। লাস্ট হচ্ছে তোর কি হচ্ছে, ইন ফিমেলের ক্ষেত্রে দ্যাট ইজ আ লাইগেশন অফ ফ্যালোপিয়ান টিউবকে বেঁধে দিচ্ছে হচ্ছে, অ্যান্ড মেলে হচ্ছে লাইগেশন অফ ইয়োর ভাসকে বেঁধে দেওয়া হচ্ছে, দ্যাট ইজ দ্য আলটিমেট মেথডস। তাহলে কি হবে ফিমেলের ক্ষেত্রে, কি হবে ফিমেলের ক্ষেত্রে যখন তুই ফ্যালোপিয়ান টিউবটা বেঁধে দিচ্ছিস, তাহলে কি হবে, স্পার্ম তোর গিয়ে আর ওভারি পর্যন্ত রিচ করতে পারছে না, তাহলে হয়ে গেল। মেলের ক্ষেত্রে ভাসে বেঁধে দিলে কি হবে, দেয়ার ইজ এ অকারেন্স অফ তোর মানে চেঞ্জ ইন দ্য তোর এই যে যখন তোর ইয়েতে পড়ানো হবে তোর মেল রিপ্রোডাক্টিভ সিস্টেম, দেখবি ওখানে আমাদের শাটলি সেল এগুলো পড়ানো হয়েছিল না, দে কজ দ্য এনভায়রনমেন্ট দ্যাট ইজ দ্যাট এনভায়রনমেন্ট প্রিভেন্ট দ্য প্রোডাকশন অফ দ্য অটো অ্যান্টিবডি অফ স্পার্ম, তাই না? ওই জায়গাটায় শাটলি সেল, ওই জায়গাগুলো মিলে একটা, এবারে তুই যখন টাই আপ করেছিস ভাসকে, দেয়ার ইজ এ চেঞ্জ ইন দ্য এনভায়রনমেন্ট ইন দ্যাট পোর্শন, সো দেয়ার ইজ এ প্রোডাকশন অফ অটো অ্যান্টিবডি এগেনস্ট স্পার্ম, তো স্পার্ম এগেনস্টে অটো অ্যান্টিবডি তৈরি আছে, তারপরে স্পার্মটা তখন কমে যাচ্ছে। ওকে, দেয়ার ইজ সাম আদার মেথড, যখন আমরা স্টুডেন্ট ছিলাম তখন এগুলো ছিল, যে সাম ইউজ সাম spermicide jelly, etc. But their use are now so much less because these products are not readily available in India. So, spermicidal jelly or cream, that is there is a concern about the availability of the product. Okay, so this is in short the contraception, their advantage and their disadvantage. ঠিক আছে, এটুকুই।